You know
Yes,
what?
I can hear.
You can hear, all right? Thank you. Hi, everyone. Good morning. I'm Kwek Kiafat, Associate Professor in Community Health at Jeffrey Chao School of Medicine and Health Sciences, Monash University, Malaysia. The title of my presentation today is on benign prostatic hyperplasia and quality of life. The content of my presentation is on what we call that overview of PPH, impact of PPH on quality of life, and the impact of PPH on partners' quality of life or well-being. WHO defined quality of life as individual perception of their position in life embedded in a cultural, social, and environmental context. The concept of QL is broad and is composed of numerous domains such as physical, psychological, social, family, and environmental. The evaluation of these domains can reveal the overall impact of illness on patients' life. Quality of life has been shown to contribute more to individuals' perceptions, well-being, health, and life satisfaction rather than objective measures of life conditions. Now, benign prostatic hyperplasia or BPH is a non-cancerous enlargement of the prostate gland, which is part of the male reproductive system. As men age, the prostate gland can increase in size, and the enlargement can lead to various urinary symptoms such as urgency, nocturia frequency, difficulty starting urination, weak urine stream, dribbling at the end of urination, straining, and inability to complete emptying the bladder. While BPH is not cancerous, it can cause discomfort and interfere with normal urinary function. Now, it is estimated that by the age of 60, roughly about 50% of men will have some degree of BPH. And by the age of 85, it increases to about 90%. BPH is less common in men aged less than 40, and the exact prevalence can vary by geographic region and population, but it is generally considered as a common condition in aging men. The severity of symptoms and need for treatment can vary widely among individuals with BPH. The graph shows the prevalence cases according to age group. The error bar and the red background indicates the 95% confidence interval. Among the causes or risk factors for BPH are age, hormonal changes such as increase of DHT, family history, ethnicity such as African American men prevalent for this BPH. Lifestyle, for example, diet high in saturated fats and red meat, and sedentary lifestyle, followed by obesity, erectile dysfunctions, chronic prostatitis, for example, inflammation can stimulate the growth of the prostate cells, and metabolic syndromes such as obesity, high blood pressure, high cholesterol, high triglyceride, insulin resistance. All these have been linked to an increased risk of BPH. Now, the BPH can have significant effects on men's quality of life, for example, on their physical health, such as it reduces their libido, difficulty in keeping their erections, and contribute to their less sexual satisfactions. Apart from that, BPH can affect men's social life, relationship, and emotional well-being. Alpha blockers are often prescribed for BPH symptoms as it helps to relax the muscles for easier urination. However, 1 in 10 men who take the medication will have problems ejaculating little or no semen since it relaxes some muscles. 5-alpha reductase inhibitors such as Proscar and Amlodipine, which are used to shrink the prostate gland, can lead to possible erectile dysfunction, reduced libido, and ejaculation problems. In a Nigerian study, the physical, psychological, social, and environmental domain were found to be affected, where 22% of the respondents with severe ED had poor quality of life. Men with erectile dysfunction consistently reported loss or diminished masculinity and was linked to depression, embarrassment, decreased self-worth, and fear of being stigmatized. The correlation between erectile dysfunction and masculinity is evidenced and supported by many qualitative and quantitative studies. This slide shows the result of a cross-sectional study among patients attending urology clinic of a super specialty hospital in Jammu, India. The result shows the patient with moderate and severe erectile dysfunction has poor quality of life domains compared to mild, moderate, patients with erectile dysfunctions. BPH can have a significant psychological impact on men. For example, men with BPH tend to have sleep disturbances, poor body image and self-esteem, social withdrawal, sexual dysfunction, which leads to feelings of frustration, inadequacy, strained relationship, anxiety, and depression. Psychological effects of BPH can vary from person to person. Some may experience only mild psychological effects, while others may find the condition maybe severely affects their quality of life. Seeking medical attention, discussing with their healthcare provider, and exploring various treatment options can help to improve their physical and psychological aspect. Likewise, with support from healthcare professional partners, support groups can also play an important role in helping them to cope with the emotional impact. BPH can also have a significant impact on their partner. For example, the sexual function changes may affect the couple's intimate life, potentially leading to frustration, reduced sexual activity, and satisfaction. Thus, the partner needs to adapt to the new challenges and provide emotional support, understanding, and patience when the husband copes with the urinary symptoms, treatments, and potential lifestyle changes. The partner also needs to make accommodations by adjusting travel plans and understanding when their partner experiences urinary urgency. They also need to open discussion to address the concerns, fears, and emotional well-being when discussing the impact of BPH on their daily life. They also need to provide emotional support and helping them to cope with the psychological aspect of BPH, such as stress, anxiety, and depression. Apart from that, they also need to navigate the roles, responsibilities, and interactions as they adapt to the challenges posed by the condition, and get involved in their partner's healthcare journey by attending medical appointments, assisting with medications or treatments, and providing a supportive presence during procedures or surgeries. Since BPH can affect the overall quality of life of both parties, therefore the partner may need to find ways to maintain a good quality of life despite the challenges posed by BPH. In a study done in 2017, 8% of men who wake up at night say it bothers the partner significantly, but 64% of women who are affected by the partner's BPH symptoms say it impacted their sleep. Also in the study, 90% of men surveyed noted that they likely seek minimally invasive procedure if the procedures carry less risk of impotence or erectile dysfunction or incontinence. Romance is still vital to women, as the healthy sex life may improve life expectancy and overall health. In another study by Metropolis and team in 2002 noted that their partners suffer disruption of social life, inability to take care of essential tasks outside and inside their house, psychological burden, inadequate sex life, fear of prostate cancer, and fear of surgery. In terms of management for BPH, there are 4 approaches, and the approaches are watchful waiting, which is for mild or minimal symptoms, lifestyle modifications, which involve diet, fluid management, and physical activity, medications such as the usual 2 alpha blockers and 5 alpha reductase inhibitors. Phosphodiesterase 5 inhibitors such as tadalafil or Cialis is to relieve both BPH and erectile dysfunction symptoms, whereas anticholinergic medications such as oxybutynin is to treat the overactive bladder. Minimally invasive procedure therapy to relieve the symptoms associated with BPH while minimizing the invasive of the treatment can also be employed, such as microwave therapy, needle ablation, vaporization, incision, and others as well. Among these therapy, which is a transurethral section of the prostate, is the gold standard for the BPH surgical treatment. And lastly, open surgery. This slide shows the results of the comparison among the medical treatments, okay, such as alpha blockers, phytotherapy such as cerurinaripans, which is the saw palmetto, and Biogen africanum, compared with 5 alpha reductase inhibitors such as Proscar, combined treatment, and compare with watchful waiting on their prostate symptom score at baseline and 6 months. It was found that the quality of life and symptoms improvement were equivalent among the medical treatments. Well, that's all from my presentation. Thank you.
Thank you, Doctor, for your presentation.
Any questions?
Any questions? From Jaipur, Rajasthan, working as an associate professor in NIMS Dental College, and it gives me immense pleasure to be a part of Third International Web Nursing and Women Healthcare. And speak my I've seen the times of despair, the helplessness, and but today I'll not talk about the negative side, what happened during COVID infection. Today I'll talk about the positive aspect, the brighter side. What happened during corona infection was that we defeated this infection and we came as survivors. And why that happened? Because of the advancements in medical innovation, that we were able to diagnose this disease early, and also we were able to detect it and treat it at the earliest possible. Now, if we see a little history, then in December 2019, in Wuhan, China, a virus of uncertain respiratory origin grabbed the China, and then within no time, it spread its legs across the entire globe. So much so that in March 2020, the WHO has declared COVID-19 as a global pandemic. Now, if I talk about my country, India, then on 30th January, first case was reported in Kerala. And after that, within a span of 45 days, about 100 cases were reported. And on 22nd March, our government imposed first day of Janata curfew, followed by 4 national level lockdowns over a span of 4 months. If we talk about what is the current situation of COVID in our country, then there are about 44 million confirmed cases of corona infection and about 5 lakh deaths due to corona infection. Now, if we see what are the reasons for the global spread, there would be plethora of reasons, and especially because of the high transmission rate, it was very difficult for us to detect this infection and then to identify this infection and grab hold and treat it. Also, the symptoms were overlapping with viral infection, so people were not able to identify whether they were having corona infection or whether they were having mild viral infection. Also, the people were not aware of this kind of virus could also be there. But where today, what I would like to focus on would be the non-availability of the quick diagnostic test. The diagnostic test available at that time was RT-PCRs, we all know, and that would take about 1 day or 1.5 days to get the results. So by that time, the infection would reach other people, and that person might have infected 10 other people. So that was one of the major drawbacks which was causing the virus to be stronger than us. If we see what is the diagnosis for the corona infection, then we can either use molecular diagnostic tests, that is we use the viral RNA using the nucleic acid amplification test. Then we can use antigen diagnostic test, in which we use the viral protein and detect the virus from its protein. Then antibody diagnostic test, which is detection using the antibodies which are generated against the infection of corona. Now, this is the table in which I've compared the various testing options, that is NAT test, antigen test, and antibody test. Obviously, with NAT test and antigen test, we were detecting the current infection, and with the antibody test, we detected the prior infection. But the specificity was very high in case of all the 3 tests, but sensitivity was high for nucleic acid amplification test. Now, let us talk about today's topic, that is point of care. Let us first understand what is point of care. Point of care is a testing that is performed at or near or at the site of the patient, with the result leading to possible changes in the care of the patient. That is, what we are trying to do is we are doing the test at the chair side or by the patient themselves at their home. And with this, what we are trying to achieve, we are getting the immediate acquisition of the test results. Historically speaking, this point of care devices are not new. We have used this point of care devices for testing blood glucose back in 1962, followed by the development of home pregnancy test kit in 1972, and they have revolutionized the way we see these point of care devices. They are now used in day-to-day practice in every home. Apart from these, various other systems are also using point of care devices to detect the disease early. They could be in the field of cardiac, coagulation, hematology, oncology, or urine analysis. Since I am a dentist and I am a periodontist, so these point of care devices are also available to detect periodontitis. I'll briefly tell you what is periodontitis. Periodontitis is basically the inflammation of the gums that is covering the tooth, supporting the tooth. So once that is not healthy, obviously the tooth becomes loose, mobile, and it sheds off. So these point of care devices help us to detect these diseases early, and as a result of which we can treat the disease early. So we can test the periodontitis using saliva, gingival clavicular fluid, and plaque. Now, talking about the point of care devices for COVID-19, this is a list of the FDA approved point of care devices. That is your Q, Lucira, QQ, Binax Novi, Ilium. Then these are the ICMR, that is Indian Council of Medical Research, have approved CoviSelf, PanBio, CoviFine, ANCARD. These are the test kits which are available and approved by ICMR. Now, if we see what are the various tests that can be done during COVID-19 outbreak, one is the screening test. Screening test means when the person is infected, but he has not shown his symptoms, that time what test you do is your screening test. Then is a diagnostic test. This is the test when the person shows its signs and symptoms, and then at that time you do your test, that is diagnostic test. And surveillance test is when there is an outbreak of corona infection and you are doing a surveillance to measure the burden of the disease in a population or community, that is a surveillance test. These point of care devices basically are screening test and diagnostic test. They can be used either as a screening test or diagnostic test. Now let us see what are the advantages of these point of care devices. Firstly, it is the low cost. It's very relatively cheaper as compared to the other lab associated testing. Then there is reduced turnover time. Reduced turnover time means that there is the turnaround time from the collection of sample to the obtainment of the result is very less in case of point of care devices. Why? Because we are getting the result within 15 minutes. However, if we see our RT-PCRs, it takes 1 day, 2 days for them to generate the results. Then since it is with them at home, the patient themselves can do a continuous monitoring of their status of corona infection. Obviously, it reduces the travel by the patients, and also the most important, it reduces the burden on the healthcare. We have seen that during corona infection, be it the first wave, second wave, or third wave, how our healthcare system was totally burdened, be it your medical professionals, nursing, dentists, they all were absolutely burdened with the kind of load we were getting in terms of the disease and the patients. So when the patient themselves can be the center where they can detect and diagnose their corona infection, it will reduce the burden on the healthcare. However, these devices do suffer from certain limitations, like sometimes the patient's acceptance is not very good because they rely more on the lab generated reports. Sensitivity for certain POCs are not very correct. So that time there is a limitation of these devices. And then we need to have that medical professionals trust that yes, these devices can give a good result. And that actually took a lot of time, but now medical professionals feel that these home test kits are actually useful. Now I'll tell you, this is what a point of care kit looks like. This is when you purchase it and you get it. This is how a point of care kit looks like. Now, for any for any detection of coronavirus, there could be a direct test and there could be an indirect test. Direct test, basically what we are doing is we are detecting the antigen. And in indirect testing, what we are doing is we are detecting the antibody which are generated against the antigen of corona infection. So these point of care kits are basically direct kits, which means we are detecting the coronaviral antigen in this. Now, what does this kit contains? When you purchase this kit, you will get a pre-filled extraction tube, a test card, and a sterile nasal swab. Now, how will you collect a sample? You need to insert the swab into the nostrils, and up to 2 to 4 centimeter, you need to insert the swab until you feel the resistance. Once you feel the resistance, you need to roll the swab 5 times in one nostril, and you need to repeat the procedure again over the next nostrils. Now, how will you prepare the sample? Sample will be prepared by inserting the nasal swab into the extraction tube, pre-filled extraction tube that is filled with the liquid. You swirl it 10 times so that the entire specimen or the sample from the nose is totally mixed with the fluid in the extraction tube. And then what do you do is you break the nasal swab at a point which is called as break point, which is already given by the manufacturers, preformed by the manufacturers. Once that is done, you close the lid, mix the extraction tube well, and then what you do is you pinch and put true drops of the prepared antigen buffer mixture into the sample well, that is of the test card, and then you proceed for the result and wait for 15 minutes and get the results. Now, how will you evaluate the results? You will see that whenever there is 2 red lines, both on the control and test side, it means the test is positive. Once only the control is showing red line and test is not showing the red line, it means the test is negative, which means that the patient is not having corona infection. And if you see that the control line is not showing any color, it means your test is invalid. Why? Because the sample has not flowed up till the entire test card and has not reached the control line. So which means to say that this control line is basically for the quality check. If your card is showing that the test control is showing red line, it means your device is correct. Now let us understand what is happening with this principle. If we see, what does this test card contain? This test card is basically a rectangular card made up of 2 parallelly arranged glass slides. Okay, now are generated against your corona antigen, and they are bound to the dye for us to detect in terms of color. Next is the detection zone, which contains a test line and a control line. The test line contains the fixed antibodies against the antigen, and the control line contains the fixed antibodies against the antibody which are present in the conjugate release pad. Okay, so this is the part of the test card. Now, let us see an example. Now, if there is a patient having coronavirus infection, what happens? If there is a patient with corona infection, it is going to have viral antigens. So once the patient is having viral antigen and you pour the sample into the sample pad, the patient's sample flows laterally through the capillary and it reaches the conjugate release pad, where this antigen, viral antigen, goes and binds to the loose antibodies against this corona infection. So there is antigen antibody complex being formed, and the whole thing is conjugated with a dye so that we are able to appreciate with our naked eyes. Then the patient sample moves further laterally, and it will be reaching the detection zone. On that, it will be reaching the test line, where these antigen antibody complex will go and bind to the fixed antibodies present onto the test line. And then this entire antigen antibody complex fixing onto the fixed antibodies is going to give a color to the test line, and the test line becomes positive, which means the patient is having corona viral antigen. This moves further, and this antigen antibody complex will go and bind to the fixed antibodies present onto the control line. in the detection zone, and the control line also shows red line, which means the control line is also positive. So this is how your test card will appear. That is, your control line and test line will both show red line, which means that the patient is having corona infection. Now, what happens if the patient is not having infection? Then what happens is, then the patient will be without any viral antigens. We are going to put the sample into the sample well. It is going to flow laterally by the capillary action, move on to the conjugate release pad. Since there are no antigens, so these loose antibodies will not be able to bind to any antigen, and they are going to just move laterally further into the detection zone. Since they are not associated with the antigen, so they will not be able to bind to the fixed antibodies in the test zone, as a result of which the test zone will remain negative. There will be no color change. However, the control line, since it is containing the fixed antibodies to the antibodies present in the conjugate release pad, they are going to bind to each other, and the dye is going to show its color, and the control line becomes positive. So this is how your test card will show when the patient is not having corona infection or your test is negative. Only the control line will be red, not the test line. Thereby, I said in my previous slides also, the control line, the presence of control line acts as a quality check whether your test card is correct or not correct. Now, having understood the principle of working for these point of care devices, let us see what is the need of these point of care devices in dentistry or in medical sector or in nursing sector. As it has been very rightly said by WHO, we thought that we will be able to see a situation where we can say that there are no cases of coronavirus in the entire world, but that is not the case. COVID is mutating itself, and they have said that the flu is likely here to stay. And this same thought has been reiterated by various scientific journals, which means that the corona is here to stay. If it is here to stay, then we must protect ourselves, safeguard ourselves from this infection. Now, according to OSHA, that is an organization which ensures safe and healthful working condition, they have put dentistry to be at very higher risk of in the occupational risk pyramid, and so is the medical healthcare professional and also the nursing professionals. Why? Because we very closely deal with the patients. Dentistry in particular is very high in occupational risk pyramid because we work very close to the patient's mouth. So our chances of getting infection is very high. So what should we do? We should safeguard ourselves, not only ourselves, but our associates in the clinic from coronavirus infection, and make sure that we are not becoming a hotspot from where actually the virus is spreading to other people. So it is our responsibility to fight against this corona infection. My society, Indian Society of Periodontology, has also put forward a guidelines in which they have said that how to have a safe periodontal clinical practice during COVID-19 time, in which they have said that pre-appointment screening is mandatory, which means whenever the patient is coming to you, like we do a regular dental history, medical history, we must also ensure that the patient is showing signs and symptoms. We must do their corona testing using these point of care devices. Normally in our armamentarium, we do keep a glucometer with us. We do keep a sphygmomanometer with us. Then why not keep a point of care device for testing this corona infection and safeguard ourselves from the infection. So these point of care devices could be used as a diagnostic test. When we see that the patient has signs and symptoms, fever, cough and cold, we can use it as diagnosis, or we can use as a screening test, which means whenever there's an outbreak of COVID cases in the city, then we can act as a center which can be able to detect these infected people and prevent the further spread of the disease. Now, with this, I would like to conclude by saying that with the advancing medical care, we all are a very important part of the medical professional team. So we must upgrade ourselves, not only in terms of advancements in medical and dental treatments, but also in the overall benefit of the community health and the patient health, and thereby protect ourselves and the entire world from such miserable infections. With this, I would like to thank you for your patient listening, and I would like to thank the organizing team for have given me this opportunity to talk among so many array of speakers across the world and put my view on this topic. Thank you, one and all.
Thank you, Dr. Nancy, for this excellent and informative presentation.
Thank you, ma'am.
Any questions to Dr. Nancy? You can see your screen.
Am I clear? Oh, it's clear. Huh? Also, my sound is clear. Okay.
Yes.
Good morning. First of all, good morning to everyone. First of all, I'd like to thank the organizing committee for inviting me for such a valuable international meeting to talk about risk factors and incidence of venous thromboembolism after total knee replacement, which is actually based in one of my published study of this topic among the Saudi population. Next slide. Oh, it's not moving. Slide is not moving. Okay. Oh.
Dr. Lutf, you can click on activate on the screen.
Is it going now? Yeah. I had some technical problem, but I think it's it's done now. We have no conflict of interest, and we didn't receive any fund or grants for studies. Ethical approval was obtained by our ethical committee and our institutes. Total knee arthroplasty, total knee replacement actually is well established as a successful procedure to treat end-stage arthritis of the knee, which is such disease is which I mean osteoarthritis of the knee is actually a progressive disorders, and it's a disabling disorders which affecting the daily activity of the life of the people, mainly the elderly, starting after 40 years of age, reach about 40%, as stated here, among 70 years old people, affecting them from even sometimes disturbing their sleep. They will have pain day and night. And this say the amount of the having osteoarthritis with the rapid growth of the aging population, more and more osteoarthritis among our populations. That means we need more or increasing the number of total knee replacements, which is now estimated to be 400,000 primary total knee performed in the United States only, and in 2030 it will be about 1.26 million procedure will performed per year, as a record history of national and patient samples. So as the total knee replacement is very successful procedure, at the same time it's well-known as a major procedure. That means major procedures, it's carrying high risk of complications. One of these complications is the developed venous thromboembolism, which is about reported between 40 to 60%, maybe more than to 80% without taking prophylaxis. The majority of these events are symptomatic, but actually it's very serious events. That means there is a considerable morbidity and mortality. If you're focusing on the mortality here, the main reason of death, such disorder or associated with such procedure, is the pulmonary embolism. Pulmonary embolism. Pulmonary embolism is one of the common disorders, and it leads to death of about 25,000 per year in the United States. 90% of this pulmonary embolism is due to DVT of lower limb. And the total knee replacement is really a major cause of DVT of lower limb. So total knee arthroplasty lead to DVT, pulmonary embolism lead to death. So it's really something you have to worry about it and to how to prevent it. We have two questions here. Let's say, why the total knee high risk of VTE. In other means, what are the risk factors leading to development of venous thromboembolism of patient undergone such procedures? This is the first question you have to answer. And second question, what is the real incidence of such venous thromboembolism, and how can we minimize it or decrease it? I mean, globally in our populations. To answer these questions, which are these, let's say, our objective of the sessions of today or our study, I'm not limiting just listing the risk factors, but I will go just very quick. I'm not really hematologist to talk about the formation. How do the clot formed? Really so quick. There is we call Virchow triad. Virchow triad. There are three conditions that precede any formation of the clot of thrombus, which are venous. I mean, venous cases when there is any condition that lead to slowing the rate or flowing of the blood in the bloodstream, blood stagnations, that could lead to formation of thrombus. And factors like mobilizations, low demanding or low activities, obesity, diabetes mellitus, congestive heart failure, other diseases, or other factors, let's say, lead to venous stasis that could predispose to thrombus formation. There is an injury, I mean to vein. Here we're talking venous thrombus. Injury to the vein, what means the vein is the inner wall, which calls the intima. Any injury to the intima that also predisposed to formation of thrombus. Surgery, of course, is a major trauma. And if you're talking about total knee arthroplasty, it's really a major surgery where there is a risk to injure the vessels. That means there is a risk of venous thrombus formation. Hyperplasia state. See, other different diseases can lead to that. As mentioned here, obesity, diabetes mellitus, could be either genetic abnormalities like vitamin C or S abnormalities. You see, and any factors lead to any one of these three conditions, that means could lead to venous thromboembolism formation. And factors, they could cause not only one conditions, maybe two conditions like diabetes mellitus could lead to venous stasis, hypercoagulability, and that increase the risk formation of thrombus by such factors. How about when we transfer this to our case, total knee arthroplasty? Total knee arthroplasty, it's multifactorial. That means patient undergo such procedures, they carry a lot of multiple factors, multiple risk factors that lead to venous thromboembolism. These factors could be, let's say, surgery related, first, or the type of surgery. Our surgery is major, would cause intima injury. That means it's lead to venous thromboembolism. The duration of the surgery, maybe it is more than 2 hours. It's a risk factors. If you do both knees at the same times, also the mobilization after the surgery, the staying at the hospital, as longer in the hospital staying, that means risk of DVT formations. Other factors, patient-related factors, like, let's say, age, female, advanced age, female genders, obesity, comorbidities like diabetes mellitus, DVT, COPD, CVE, inflammatory bowel disease. And all these comorbidities are really risk factors to lead to formation of venous thromboembolism. You see how is that? Why is that the risk factors of total knee replacement associated with total knee replacement? Because they are not only single factors, they are multiple factors that makes the risk of DVT's formation with for patient undergoing such surgery is very high. If you translate that to scores, there are different according to the American Academy of Chest Physician, American Academy of Orthopedic Surgeon, and identified by Cabrini. They have listed, they have given scores to each factors. In the first column, let's say here, all these factors, they are having one score for each factor here. But you go to the to maximum right here, each factor here will be scored as 5 points. And if you go down here, it's a major lower extremity arthroplasty. That means here the total knee arthroplasty. Just the procedure by itself will be giving 5 points. Okay, 5 points. Down here, according to the scoring system here, they have stratified the risk, the patient and the procedures to low risk, moderate, high, with patient having only 0 to 1 point, that is low risk, 2 moderate, 3, 4 higher risk. And if we score this procedure or the patient 5 points, that means very high risk. If we focus that, highlight it in our procedure, TKR, the TKR by itself just given 5 points. If we add another factor, which is the age group between 60 and 74, where most of our patients undergone TKR, they are among this group. So that will give 2 points, plus the 5 points of the procedure itself, that means 7 points. If you add another factor, let's see the duration of the surgery. If it is more than 45 minutes, also there's 2 scores. Our surgery here could be 1, 2, 3 hours. That means there's another 2 scores. That means 2 plus 2 plus 5, 9 scores. So that's only these factors. I'm not going to add any other factors. And that put our total knee procedure replacement is very, very high risk group. If we just link our very high risk total knee in the form of percentage here, and that may be the answers of the first answer of the second question: what are the incidents of the DPT among total knee replacement? You see the total knee replacements, it's here for high, very high risk, certified, classified, and very high risk. In this very high risk, the DPT percentage is 40 to 80%, and the pulmonary embolism 0.2 to 5%, which actually considers high. This is the fatal pulmonary embolism, not asymptomatic. It's symptomatic, acute, fatal, that could lead to death. So the answer of second questions. First of all, we talk about the why is a very high risk procedure to develop VTE. Here, how can we decrease this VTEs? How can we decrease the death rate, comorbidities associated with such procedure? We decrease it. Yes, you can decrease that by giving prophylaxis. It's very highly recommended. You must give this prophylaxis, and the prophylaxis, most of it given by the medications here, right? Different types of class of medication. It's not the scope of our today talk, like heparin, low-molecular heparin, warfarin, oral. They have an oral, and even aspirin nowadays, which is actually nowadays an aspirin. It is maybe the method of choice. In addition to the medical or pharmacological prophylaxis, we could plus minus what you call mechanical, which is like you give compression devices, which could be pneumatic compression device, where is an air inflated through these devices, and we can control the pressure. We could be stockings, compressive stockings. Also, in addition to prophylaxis, pharmacological and mechanical, by modifying the risk factor. For example, diabetic patient, if you control the random blood sugar, that could minimize the risk. But one really very important factor is early mobilizations. We have to mobilize our patient as soon as possible after the surgery, because that will decrease the venous stasis and decrease the risk of actually DVT and pulmonary embolism. If you now talk about our studies among the Saudi population, focusing on these 2 points, risk factors and the incidence rate of VTE, it is actually prospective studies in our hospital, Jeddah, Saudi Arabia. Most of these demographic clinical radiological data collected from the clinical medical records. The diagnosis of VTE based on clinically means there is symptoms and be confirmed by Doppler ultrasounds. In case of PE, CT angio is the method of choice of diagnosis of the PE. We use the IBM SPSS version 22 to analyze our data. We have 348, not 380, sorry for that, were included in this study. Most of the cases were unilateral, I mean, one knee done at one sessions. Only 48 were bilateral. Bilateral means two knees done at one sessions. 15 had stage bilateral. Stage bilateral, that means I do one knee in one sessions and the other knee later after 1 week, 1 month, 2-3 months. It is up to the surgeon itself. Most of our patient females, 73.9%. Mean age was 64.4. Mean BMI was 35.15. 98% of the patients will have osteoarthritis. What is the incidence of VTE in our population? It's about 2.3% VTE, 1.4% were deep vein thrombosis, and 1.1 pulmonary embolism. One patient had both conditions, VTE and pulmonary embolism. About 1.4% of our patients were diagnosed inpatient, I mean before the discharge, and the rest after discharge. Regarding the factors, age, gender, BMI, actually we found to have no significant relationship with the development of VTE in our studies. Regarding the bilateral total knee, also there was no statistical difference between doing bilateral or unilateral. I don't know. What about the main length stay of the patient in the hospital? The stay as your patient staying longer in the hospital, that is really proven to be a risk factor. The patient developed VTE in our studies. The main length in the hospital was 17 days, while the patient did not develop VTE. The mainstay in the hospital was about 10 days, 10.88 days. So the length of stay at the hospital is a risk factor to develop VTE in our studies. Diabetes mellitus actually was found in about 35.9, I mean 36% of us, which actually was found to be a risk factor for developing DVT in our studies. Pre-operative prophylaxis was given to 44.7% of our patients, while 55 did not get it. But actually giving preoperative prophylaxis to prevent VTE was not shown in our study to have a risk factor. So there is actually, it's not recommended by our studies. The start of main post-op mobilization day was longer in patients who develop VTE. So that means any delay in the mobilization of the patient post-op could lead to VTE. So as we said, early mobilization is recommended. So the delay of post-op mobilizations, it's really have a significance to develop VTE. It's a risk factors, I mean. These are the timetables of our risk factors, demographic data of the patient. We have been through. No need just it's there for anyone to want to review it later on. Okay. Compare our study to studies of other institutes. In our study, the DVT incidence was 2.3%, which is really comparable or similar almost to studies to other studies, which is, or let's say globally, which is 2 to 3%. And that, for example, it's the studies done by the John White and Megrin et al., even with studies done by Bach, included 205 patients, which is actually it's and the same population showed the incidence 2.4%. So our rate or incidence of DVTs in our studies is really comparable or similar to other studies. Even the percentage of or incidence of VTE among our inpatient was 0.4%, which is also comparable to the reported by General et al., which is 1.9%. If we compare now the risk factors that proven in our study to be risk factor for developing of DVT and VTE, also pulmonary embolism, diabetes mellitus, which is generally considered a risk factor VTE, and that's also proven in our study that diabetes mellitus was really a risk factor for VTE in our TKA patient, but other studies or some studies did not that there was no strong, let's say, evidence to be proven that diabetes mellitus is a risk factor for VTE. That study, but can, let's say, recommend for that diabetes mellitus is a risk factor. It is known that at least to be associated with lower risk. So we have to consider always diabetes mellitus as a risk factor for such cases. What about air mobilization? We said air mobilization is so essential, important to decrease the venous stasis. By decreasing the venous stasis, we could decrease the development of surgeon to enhance the early mobilizations. And as you said earlier, the delay of post-immobilization was really significantly associated with VTE, which is also consistent and with the result and findings of the other studies. The length of stay of the patient also considered a risk factor in our study, even in the other studies of other institutes. What about the history of previous VTE? A patient having previous history of venous thromboembolism. Actually, according to the American Academy of Orthopedic Surgeon, there is no, and the current evidence is not clear whether other factors other than VTE can affect the risk of VTE post-TKR. In our study, actually, such factor, which is the history of previous VTE, did not show to be a risk factor for development of VTE in our study. Bilateral total knee, as we mentioned earlier, did not show also or has not proven to be a risk factors versus unilateral total knee in our studies. Maybe there is few studies have really shown that bilateral total knee replacement is a risk factors for VTE. Other factors like advanced age, female gender, CVE, congestive heart failure, obesities, longer operation time, were really associated with the VTE as suggested by the other studies, but actually these findings of other studies is not really going or consistent with the findings of our study regarding these factors. So in summary, home message, total knee arthroplasty is a successful procedure for end-stage knee osteoarthritis. And but really, as we said, patients undergoing such procedures really carrying or at high risk to develop VTE. How can you prevent it? There is agreement, general agreement that you must give prophylaxis, either chemical medication plus minus mechanical, and modifying the risk factors, particularly early mobilizations. The second important point as a home message here, the formations of VTE after total knee is really multifactorial. That means there's, as we said, there's multiple factors leading to VTE, which is, as we said, surgery-related, patient-related factors. In our studies, only these factors proven to be risk factors to VTE, which are diabetes mellitus and delayed post-mobilization and length of stay. Thanks, I'm done now. At the end of the slide, there's one, I've got different indications prescribed for or recommended to prevent the VTE formations. طبعا it's not the scope of our study, but for anyone to want to review it, try to go through it, it is there. Thanks. I'm done. Any questions, please?
Thank you, Dr. Lutfi, for this excellent presentation. Any questions?
But anyway, anyone can email me for any further informations or questions, by the way. I'm really ready to answer it and to contact any time. And at the end, I would like to thank you again, all the advisory committee, and for listening to me. A chance meeting.
Thank you, Dr. Lutfi. So as you mentioned that
and I am delighted as the third international webinar on nursing and midwifery invited me, and my topics is a multi-center non-comparative study to evaluate the efficacy and safety of fixed dose Olmesartan Amlodipine in hypertensive patients. And this is all my disclosures. And we know the hypertension, the high blood pressure is a long-term medical condition in which the blood pressure in the arteries is persistently elevated. The systolic blood pressure is 120 or below normal range, diastolic blood pressure 80 or less in every guideline said it. And the 95% cases, there are essential hypertension where the cause is not known. Still, it is challenging for us because hypertension causes a great mortality and morbidity, the main risk factor of cardiovascular diseases. And there are also secondary hypertension where the cause is known. Only 5% cases, the secondary hypertension. And what is the prevalence of hypertension? That is the increase from 26% in 2000 to 29.2% in 2025, which will be approximately 29% of the world population. So a huge number of hypertensive patients are adding day by day, and it is challenging for us. And according to WHO, in 2019, an estimated 17.9 million people died from cardiovascular disease, representing 32% of all global death. Among them, 85% were due to heart attack and stroke. And hypertension and diabetes mellitus is one of the main cause of cardiovascular diseases. And what is the classification? There are many guidelines of which classification of hypertension, like the American Heart Association, European Society of Cardiology, also the well-known 2020 International Hypertension Classification. And they have the American Heart Association. They said that the normal blood pressure systolic less than 120 and diastolic less than 80, but elevated 120 to 129 and diastolic less than 80. And high blood pressure, that is the stage 1 hypertension, here they demarcated 130 to 139. In this level is stage 1. Or diastolic blood pressure 80 to 89. But it differs in case of European Society of Cardiology and also International Society of Hypertension. So there are variation between the guidelines. Here the stage 1, but they said it label it as the high normal blood pressure. And high blood pressure, that is the stage 2, is according to AAJ 140 or higher, or diastolic 90 or higher. And hypertensive crisis, that is the higher than 180 or diastolic blood pressure more than 120. And this is the classification of International Society of Hypertension 2020 guideline. They say to normal blood pressure less than 130 and diastolic less than 85. So a little bit difference with the AASA guideline. And high normal blood pressure 130 to 139, 85 to 89. They marked is as high normal level, whereas they AASA marked is as stage 1 hypertension. And here grade 1 hypertension is 140 to 159, and diastolic blood pressure 90 to 99. And grade 2 hypertension 160 or more, diastolic blood pressure 100 or more, according to the International Society of Hypertension. And how do you see the hypertension causing us a lot of complication of hypertension like chest pain, heart attack, maybe MI, heart failure. There may be atrial fibrillation, which may cause sudden death, and hypertension also causing a stroke, and also it may damage the kidney, leading to kidney failure. So yeah, and the main thing is that the hypertension is dangerous. Why? Because an estimated 46% of adults with hypertension are unaware or that they have the condition. So near about 50% patients are not aware that they have hypertension, and 50% has no control of hypertension according to the scenario. And so hypertension is a silent killer, because after the if it is not controlled, there may be the damage to the heart, brain, kidney, and also the eye. For this reason, it is essential that blood pressure should be measured regularly. And AHA guideline recommends regular blood pressure screening, lifestyle modification, and drug therapy. And we see every 2 millimeter mercury decreases in mean systolic blood pressure result in 7% reduction in the risk of ischemic heart disease mortality and 10% reduction in the risk of stroke mortality. So we should control or reduce both systolic and diastolic blood pressure. And what may be the complication consequences of hypertension? That there may be brain stroke, there may be ischemic stroke, maybe hemorrhagic stroke, there may be hypertensive retinopathy, heart failure, heart attack, there may be kidney damage, there may be peripheral vascular disease, also there may be sexual dysfunctions. And regarding the treatment, what may be the treatment? What should be the treatment? In this slide, we see here, according to AHA guideline, the initial therapy should be AC inhibitor or ARB plus calcium channel blocker. Whereas it different in the NICE guideline. They said that the people who has less than 55 years, drug should be A, that is AC inhibitor ARB. And the people who are over 55 years, drug should be C, that is the calcium channel blocker. If calcium channel blocker causes edema, then diuretics may be added. But in this guideline, here the initial therapy should be A plus C or D. It is also in case of International Society of Hypertension 2020 guideline in the management, they also said low dose of A plus C in case of stage 1. And in stage 2, full dose of A plus C. And here, step 2, triple therapy, A plus C plus D. And step 3 management, that is the resistant hypertension, A plus C plus D plus, we should add additional spironolactone or other diuretics, and we can add alpha blocker or beta blocker. Here, beta blocker come. So, beta blocker is not initially used as antihypertensive drug, and beta blocker is no longer used as pure antihypertensive first-line drug. So drug treatment strategy varies in different guidelines. Here is the summary of this. I will not go through all this. Now my study, that is the updated study from Bangladesh on Olmesartan, that is the ARB and Amlodipine combination. The study done in the 50 investigators all over the country, and it is just done in the 2020, and it is published in the World Journal of Advanced Research and Reviews in 2022. And the title is a multicenter non-comparative study to evaluate the efficacy and safety of fixed dose or Olmesartan and amlodipine combination in hypertensive patients. And what is the objective? That to evaluate the efficacy and safety of fixed dose combination Olmesartan amlodipine in hypertensive patient in Bangladeshi population. And the study period from January 2020 to November 2020, and study population finally total 443 Bangladeshi adult patients with hypertension. And the design was open label, non-randomized and non-comparative observational study. This is our limitation, that is non-randomized and non-comparative. And Bangladeshi adult patient with hypertension are included in this study. Adult male or female patient with a prescription of tablet Olmesartan amlodipine for hypertension is included in this study. Previously never treated or not treated for at least 4 weeks before entry into the trial. These patients are included in this study. And patients who are uncontrolled by monotherapy, they are hypertensive but are uncontrolled with monotherapy, they included in this study. And the exclusion criteria that the secondary patient has secondary or malignant hypertension, they are not included. Severe heart failure patient, malignancy requiring treatment, and non-serious hepatic or renal dysfunction, serum creatinine level 2.5 or more is not included. Any compelling indication for any other antihypertensive drugs, and history of serious adverse drug reaction of angiotensin 2, type 1 receptor blocker or calcium channel blocker who has hypersensitivity reaction, these patients are not included in this study. And all patients were followed up for a period of 12 weeks. And initial at the baseline visit, that is the visit 1, and then we follow up at 2 weeks, that is visit 2, and visit 3 after at 6 weeks, and after 12 weeks, visit 4. The 4 visits are taken, and the baseline data and all the documents are collected in a data sheets. And the safety margin is the primary efficacy variable. That is the mean changes from baseline in the seated diastolic blood pressure from baseline to 12 week. That is the primary efficacy variable. Secondary efficacy variable is the mean change from baseline in the seated systolic blood pressure and systolic diastolic blood pressure baseline to week 2, 6, and 12 weeks. The proportion of patient achieving the target BP, and after 12 weeks, the how much the blood pressure, goal of target blood pressure achieved. This is the efficacy is determined by this way, and the primary safety variable, the percentage of patients who withdraw from the study due to adverse event, how many patients, and secondary safety variables, the total number of treatment emergent adverse event and adverse drug response, serious drugs adverse event among the patient. These are the secondary safety variable. And what are the results of the study? And the number of study participants, the total enrolled patient 1095 patients, and the first follow-up completed only 986 patients. Second follow-up completed 877 patients, and the final total enrolled patient is 443 patients. And what is the characteristic? That is the variables. Here you see the maximum numbers of patients are in the group of 46 to 59 years. That is the 44.9%. In this age group, maximum number 44% population added, and their blood pressure, systolic blood pressure 168 plus 16, and diastolic blood pressure 98 plus minus something. So the highest age group 46 to 59 years, and then come to the 36 to 45 years, and that is the 20% patient, and their systolic blood pressure 165 plus something, and diastolic blood pressure 100 plus something. And the female a little bit lower, 44.7% female patient, and male patient 55 patient. patient included in this study, and their blood pressure shown 167, 67, 168, and diastolic also 98 plus minus something. And BMI, we see that the high underweight, optimal overweight, and obesity. We see the overweight patient are more participate in this study, 51.5%, and these are the other systolic and diastolic blood pressure. The maximum patient are non-smokers, 61.8% patient were non-diastolic and diastolic. Positive family negative hypertension, 50% family history of hypertension, 50% has no family history of hypertension, and the blood pressure included here is like this. And so what is the dose of drugs used? And can you hear me?
Yes, doctor.
Yes, okay,
Yes.
thank you.
Yes, yes,
Thank you.
yes.
And the frequency that is 70 in this drug, 5/20 millimeter mercury once daily dose. 75% patient were given 5 milligram amlodipine and 20 milligram olmesartan combination dose, and their systolic blood pressure 164 plus minus something, diastolic blood pressure 97 plus minus something. And we use 5/40, 5 milligram amlodipine, 40 milligram olmesartan. This group use 21.9%, and 5/20 milligram BD dose use only 2.4% of the BD dose twice daily. Their blood pressure like this. So this group are given the drugs, and we follow up it 2 weeks, 6 weeks, and 12 weeks later. And medical history is the dyslipidemia, 14% patient, diabetes 28% patient, and CRF, chronic renal failure, 4% patient. And the blood pressure are shown here. And what is the sense? Here we see the first visit, second visit, third visit, and the fourth visit. What is the difference? At the blue color is the systolic blood pressure decline, and the red color is the diastolic blood pressure decline. And the visit 1 and 2, between the visit 1 and 2, you see systolic blood pressure reduced 22 millimeter of mercury, diastolic blood pressure reduced 10 millimeter of mercury. And after the second visit, systolic blood pressure reduced 9 millimeter mercury, diastolic 4 millimeter mercury, and finally, between the visit, we see the systolic blood pressure decline after using the combination pill, that is the Olmesartan and amlodipine combination. After the 12 weeks, here we see systolic blood pressure reduced 36.61 millimeter of mercury, and diastolic blood pressure reduced 18.69 millimeter of mercury. So it is a good result for the study after using the combination and fixed dose combination drugs, that is the Olmesartan and amlodipine group. We found these results. And what are the target blood pressure achievement among the patient? The target BP is known, that is the less than 120 systolic blood pressure, and diastolic blood pressure less than 80. Every guideline says this. This is the normal level. So to this target level BP achievement, in case of systolic blood pressure achieved 92.3% target blood pressure achievement occur in case of systolic blood pressure, whereas diastolic blood pressure target BP goal achievement is 98.3%. That is the very much significant. That is the target BP of diastolic blood pressure more achievement in case of diastolic blood pressure 98.3% and systolic blood pressure 92.3%. And BP goal in respect to age. Here we see the age group less than 35 years, the goal achievement 96%, highest level achievement in the lower age. And you see, and here you see 36 to 45 years, the BP goal achievement 90%. And more the age, that is the more than 60 years, target BP goal achievement 89.3%. So we can say less the age, more the target BP achievement with this combination pill. And where NLC BP goal in respect of BMI, here we see that the obesity patient has 95.8% target goal achievement, and underweight patient 60% target goal achievement occur. And here we see BP goal achievement in respect of family history. Positive family history has 88.9% BP reduction, whereas no family history of hypertension, that is the achievement 94.3%. So family history negative, that is family history has not hypertension, more achievement of target BP goal. And here you see the drug when we given 5/20 millimeter combination pill, that is the Amlodipine and Olmesartan combination, fixed dose combination once daily when we given, that is the 95.9% target BP goal achievement occur. And when we give 5/40 millimeter once daily dose, it in the 5/20 millimeter mercury once daily doses. And here you see the in the short, that is the when the age group 36 to 45 years, 90.8% target BP achievement. More achievement occur in the less than 35 years, 96% in group. And the the obesity, obesity, when the patient is obese, 94.8% target goal achievement occur. And the C respect for the family history of hypertension, and the family we use 5/20 millimeter mercury once daily dose, highest highest level of target BP goal achievement occur, and all are statistically significant. So between visit 1 and visit 4, the targeted systolic blood pressure was achieving among 92%, and the diastolic blood pressure was achieved among 98.3% of participants. So among all the patients, a total 15.2% reported treatment emergent adverse event, only 15.2% patient. And there was no discontinuation of study medication due to intolerance or adverse event, and there were no serious adverse event. So, conclusion, Olmesartan and Amlodipine is an effective combination for the management of hypertensive patient of Bangladesh. Future study of Olmesartan and Amlodipine in Bangladesh could be conducted with a longer treatment duration to examine the maintenance of effect and long-term safety, and could attempt to examine the dose-response relationship and factors associated with response in further detail. And with this, thank you very much for patience hearing.
Thank you, Dr. Muhammad, for your presentation. Any questions to Dr. Muhammad? Okay, thank you. Okay, I will start. The American Artificial Intelligence Research Group OpenAI created and released ChatGPT as an online chatbot and personal helper in November 2022. It is built on the GPT-3 model, which creates human-like writing and lifelike communication with its end user using artificial intelligence technologies, including deep learning, machine learning, conversational linguistic synthesis, and massive language framework. So from its very introduction, the platform has grown in popularity among several demographic groups. The artificial intelligence tool, ChatGPT, has gained popularity in less than 2. The response is mixed, with some praising for its benefits and future uses and others criticizing it for its constraints and potential downsides. So we must return to the start of the GPT series of models to comprehend it. Generative pre-trained transformer is what GPT stands for. In particular, the domain of learning algorithm has undergone substantial transformation as a result of the original research, which was published in 2018. With only a little amount of new data, this model may be instructed to produce state-of-the-art results across a variety of search categories. The following generation, GPT-2, was introduced in 2019. While it had significant change, this model's constructions was comparable to that of its forerunner. Due to the size and infrastructure requirements, updating the framework was already a challenging process because it had 10 times as many parameters as before. Also, it modified the web text data that was used to train the system. Several newly developed features in the design were produced by these improvements. The capacity to create cohesive language and few-shot learning are the first two. This means that the software may learn from a few cases and activities that the model had never seen during its original training without having to reconfigure the model. So GPT-2 was used to generate pictures because it could produce news headers that were lifelike. Also, it was unsuccessful when it was attempted to be modified to provide communicative solutions. Also, furthermore, this leads us to GPT-3, which was introduced in 2020 and had several updates through 2022, including ChatGPT. Once more, the infrastructure was not greatly altered, but the database was altered and the amount of model components rose from 1.5 billion to 175 billion. They incorporated a ton more information from the web, including updated web text, Common Crawl, and Wikipedia. Moreover, GPT-3 advances the state of the art in several categories and enhances zero-shot learning. Like many foundational models, displayed bias about issues like gender and religions, as well as it showcased its strengths and weaknesses, which will be brought to discussion. The main function of ChatGPT is to stimulate human interaction based on user-generated requests or instructions. In principle, it is comparable to software programs and personal assistants like Apple Siri and Amazon Alexa. Yet, it is built on more sophisticated, monitored learning and reinforced learning techniques employing massive language models, and given its abilities, it stimulates real dialogue. Moreover, it is regarded as one of the most significant artificial intelligence systems ever created, and it is the largest non-sparse linguistic framework. It is challenging to determine whether a text is produced by an individual due to the caliber and complexity of the writings it produces. The chatbot can do many things. It can produce writing that is comparable to that of professional artificial intelligence copywriters. Studies have revealed that it is even capable of writing music and creating fictional works like short tales. It can also assist technical writers or content producers in creating a strategy. It can aid technical writers or content producers in creating a strategy also, and large amounts of text may be summarized, analyzed, and explained by the chatbot. So writing computer software is a fascinating additional use of ChatGPT. The ability also to fine-tune ChatGPT answers and general efficiency is yet another benefit. Although relying on already developed huge language models, there is still possibility for growth through proactive learning. A user can give extra input in addition to upvoting and downvoting a specific answer. On the flip side, the fact that ChatGPT has a tendency to create sentences that appear accurate or compelling but are actually false or illogical is one of its main critiques and drawbacks. Language models frequently experience hallucination, a phenomenon that is known as such. Moreover, it offers no sources or citations regarding where to find the material. It is not optimal to use this chatbot by itself or electronic tracking and investigation. The version then was released in November 2022, can only give details on things that happens into 2021 and before. As it proceeds to draw on data based on writings produced by humans, it will reveal more current happenings. Notwithstanding this flow, consumers should be aware that it only has a restricted grasp of truth because it relies on outdated records. In addition, data from the Common Crawl database, which includes copyrighted items from commercial corporations as well as individual writers and academics, was used to create GPT. Specialists have also cautioned about the possibility of using artificial intelligence-based applications for cybercrime. ChatGPT and other variants are subject to possible legal charge and regulatory requirements. As for academia, many academia organizations have prohibited its utilization. Since its findings are based on human-generated materials, academics and creators have been concerned about copyright violation. Nevertheless, because of conversational artificial intelligence systems are still in its initial phase of growth within the academic industry, there is a desire for consumers to run tests with it to ascertain its advantage and disadvantage in the specific sector. Present studies show that artificial intelligence systems are an unordinary procedures within the domain of academia. Yet, there is a current research that indicates that employing chatbots in academia is likely to increase learning outcomes and student satisfaction. By altering the educational process to be more participatory and reactive, chatbots have the promise to enhance participation, socialization, and effective learning in higher education. Students may gain from the employment of chatbots in educational settings by having faster, more effective access to knowledge. Also, it has been recommended that chatbots can be used in e-learning environments to evaluate learning preferences and collect feedback. Students may find motivation from chatbots to continue having conversations for instructional purposes. However, the insights of teachers and other key informants should be taken into account while developing chatbots for use in academic environments. Concerns abound on how ChatGPT will alter academia. It can create state and on a variety of subjects. If anything, the consequences for academia may encourage professors to reconsider their curricula and assign challenging problems that cannot be answered by artificial intelligence. As for the impact on research, the impact of ChatGPT on the creation of scholarly publications are more concerning. In a recent research, academic examiners were given abstracts generated using ChatGPT, and only 63% of the artificial intelligence generated content was detected. That much artificial intelligence generated material may soon appear in publications. Scientific journal authors have always been required to sign a certification attesting to the originality of their work for many years. The phrase original is sufficient in scientific publications to indicate that content created using ChatGPT is unacceptable. After all, it was lifted verbatim from ChatGPT. Contributors attest that the content in the publication is their own work. So to be clear, journals are now changing their licensing and editorial guidelines to state that neither figures, photos, or graphics created using ChatGPT or any other artificial intelligence tool may be used in the manuscript, nor may they be the results of such technologies. A breach of these guidelines will be considered scientific misconduct, much like using manipulated photos or plagiarism previously published work. So this modification does not apply to the numerous collection data sets that are created by AI for use in research publications. However, ChatGPT presents a new possibility of examining novel ideas and research questions and a new research topic. Also, another concern is substituting technology for activities that need human connection, including customer service support or even psychological therapy. However, this argument is far from realistic. AI capacity for creativity and solutions is entirely constrained by the amount of data presented to it. As a result, it can only react to that and produce the results. While AI can only think within the box, humans are capable of outside the box thinking. As artificial intelligence lacks soft skills, it is unable to mimic personality growth, effective interaction, or innovative thinking, all of which are crucial for success in any industry where individuals with these traits are needed. Since artificial intelligence cannot experience or react to biological or natural environments, it lacks emotional intelligence. There is an emotive connection between employees and the employer, and machines cannot create social and emotional connections the way people can. So a counter argument would be that AI might even contribute to the emergence of new opportunities, of new job opportunities, such as AI engineers and analysts, labor or artificial intelligence business development manager. In conclusion, the outstanding foundational models like GPT suggest a science that is advancing, but these achievements need to be examined. It is mandatory to pinpoint their weak points so we can fix them in subsequent versions. There is no question that a highly exciting future lies ahead of us given the pace at which these developments are occurring. But it is also implied that everyone working in the field, as well as those in all other disciplines that decide to support it, must assume a great deal of accountability. Thank you. Any question? Okay, there is a question in the chat box. How can ChatGPT be used effectively in nursing education? ChatGPT can be effectively utilized in nursing education to enhance learning and support student engagement. Firstly, ChatGPT can provide students with on-demand access to information, answering their questions in time. Also, it can offer explanation, clarify concepts, and provide guidance, for example, on complex topics. Also, it can simulate patient scenario, allowing students, for example, to practice critical thinking, decision-making, interaction in a safe and controlled environment. Also, it can facilitate collaboration and enable students to engage in discussion, also exchange ideas and shared experience. Overall, nursing education can be enriched through ChatGPT, provide students, for example, with personalized support, interactive learning opportunities, and practical application as well for of knowledge. Also, there is another question. Can you please highlight the implication of ChatGPT in nursing practice field? Okay. As for the implication of ChatGPT and nursing practice as implication, for example, it can help in decision support. ChatGPT can serve as a valuable tool for nurses, for example, in clinical decision-making. Also, regarding patient education, it can assist in patient education by offering clear and concise explanation, for example, of medical conditions, procedures, and treatment plans. Also, it can help in clinical documentation by automating certain tasks. For example, it can generate structured notes on verbal or written input from nurses. And this will save, for example, and reduce the burden of manual documentation. Also, the ChatGPT also can bridge language barriers and enhance cultural sensitivity in nursing practice. For example, it can offer real-time translation services, allowing, for example, nurses to communicate effectively with patients who speak, for example, different language. Also, as for example, for continuous learning and the professional development, it can support also professional development for nurses, for example, by delivering personalized education resources and also recommend relevant research articles, for example, provide updates on the latest advancement in nursing practice. Okay, no question. Okay. Okay, moving to the next speaker. Okay, our next presentation it will be neutrophil to lymphocyte ratio and the platelet to lymphocyte ratio. Are they markers of COVID-19 severity or old age? A comparison.
Thank you, Zahir. Okay, as you also presented me, I am Dr. Nadia Kagansky. I am the director of a big geriatric center in Israel, and we are presenting you our work, neutrophil to lymphocyte ratio in platelets to lymphocyte ratio as markers of COVID severity or frailty, a comparison of two distinct cohorts. During COVID infection, we had two departments of COVID patients, and we have a lot of data about their laboratory measurements. So I want to present you some of these. This work was published in Frontiers on July this year, so you can see the full work in Frontiers. I want to say you some words about our center. It is a relatively big geriatric center. We have 9 departments. We also receive patients with acute diseases. It is not chronic northern hospital. It is acute general hospital, however, for patients at the age of 65 plus. You see here 2 kinds of buildings. One kind is usual big building, and another kind is small buildings that our elderly patients can feel there as they feel at home surrounding. So the SARS infection has caused a life-changing pandemic, treating millions of people all over the world. And clinical presentation of COVID ranges from asymptomatic mild disease to very severe disease. One of the problems, how can we predict the patients that will deteriorate? And we can see now a lot of researchers with different prediction factors such as clinical, rentgenological, anthropometric, laboratory, chronic illnesses, and still we are searching for such predictors. On the other hand, we have in our hospital elderly patients, and they are also in a risk for deterioration. And they are also have a risk for deterioration in COVID disease especially. We know that the number of chronic diseases rise with age. Frailty states rise with age. And still many elderly patients survive COVID. We saw this in our hospital. So how can we predict who will survive and who will deteriorate? We point to cytokines. Cytokines is an inflammatory factor, signaling molecule that's secreted from immune cells and promotes inflammation. Inflammatory cytokines are predominantly produced by T helper cells and macrophages and involved in the upregulation of inflammatory reactions. Therapies to treat inflammatory disease include monoclonal antibodies. Inflammatory cytokines include interleukin-1, 12, 18, tumor necrosis factor, interferon gamma, granulocyte, macrophage, colony stimulating factors. But we have many cytokines, but there are problems with these factors. First of all, excessive production of inflammatory cytokines contribute to inflammatory diseases that have been linked to different diseases such as atherosclerosis, cancer, depression. It causes disbalance between pro-inflammatory and anti-inflammatory cytokines. Aging also plays a role in the amount of inflammation from the release of pro-inflammatory cytokines. And we have another problem. We need more simple laboratory markers in everyday practice. It's expensive. It's complicated to check cytokines. And during last years, we found new markers of inflammation. The neutrophil to lymphocyte ratio and platelets to lymphocyte ratio. Very simple. All hospitals, even ambulatory clinics can make this laboratory investigation and calculated these counts. Many prior studies suggested that they have a prognostic role in various medical conditions such as malignancy, cardiovascular diseases, urinary tract infections. One moment. I do not see my sharing. I have not seen my sharing. Oh, no. Now. Now, and what is the paradox in elderly? Several studies have found that these factors, NLR, you remember, neutrophil to lymphocyte ratio, and PLR, platelets to lymphocyte ratio, to be prognostic factors of COVID-19 severity with higher values, representing a more severe disease and poorer prognosis. On the other hand, frailty and age may also influence NLR and PLR references. So frailty and age are also significant risk factors for severe COVID infection. This stature has the potential to cause a significant bias in the studies of NLR and PLR in COVID-19 elderly patients. In Israel policy, we have some special things of routine screening for SARS among all nursing home residents. So this policy saved life for many elderly patients. They're dependent in function, but asymptomatic because it is screening policy. They were isolated and managed in designed COVID-19 departments and skilled nursing homes departments. Patients with disease considered moderate or severely were mostly admitted to general hospitals. The policy created two diverse cohorts, one of older, frailer adults with mild disease, and the other of hospitalized patients with more severe disease. Due to this division, we aim to evaluate which of these pools has a more significant impact on NLR and PLR in COVID-19 patients. The first cohort was comprised of patients who were positive for SARS with mild or asymptomatic disease, and the second cohort included patients admitted to the affiliated large hospital. I'll call it General Hospital, GC, and Geriatric Medical Center, GMC. During 1 year, inclusion criteria was admission to COVID departments, either geriatric or general, and data included age, gender, demographic variables, comorbidities, disease symptoms, medications, laboratory tests on admission, calculated inflammatory markers. The aim of the study, to examine association of the collected data with the NLR and PLR. I want to remind you, NLR is a ratio between the absolute neutrophil count and absolute lymphocyte count. Normal range between 1 to 2. It is ratio. The values higher than 3 and below 0.7 in adults are pathological. PLR is a ratio also between the absolute platelet counts and absolute lymphocyte counts. A normal range is between 90 to 120. Here you can see the results. Data were collected from 177 patients admitted to COVID-designed geriatric medical center and 289 patients admitted to general hospital. The cohort you see here was significantly different. GMS cohort was comprised of older adults in need of continuous supervision and help in their basic activity of daily living due to limitation in physical or mental status. Patients in the GMC group were on average over 3 decades older, here see, than HC group. Only 38% of GMC patients were men compared to 54 men in the general hospital. The majority of the GMC patients were nursing home residents. 80% of GMC patients had more than 5 chronic diseases compared to 8.3 in the HC group. All the patients in the GMC cohort were frail, with the clinical frailty scale more than 5, whereas frailty was not accessed in the HC group. What we can tell about basic medical data? Risk factors for severe COVID-19 were significantly more prevalent in the GMC group. You can see here a number of diseases: hypertension, diabetes, chronic cardiovascular diseases, chronic kidney disease, malignancy. On the other hand, BMI and chronic respiratory diseases did not differ between two groups. Patients in the GMC group also suffered significantly more from dementia and depression. The majority of patients in the GMC group had polypharmacy, see here, total number of medications more than 6, compared to only 12% in the HC group. Antihypertensive medications, beta blockers, antiplatelets, anticoagulants, and insulin treatment were all more prevalent in the GMC group, representing the high disease burden. Vitamin D supplement, antipsychotics, and antidepressants were also more prevalent in the GMC group. You see this here. All common disease symptoms were significantly more prevalent in patients that were admitted to the HC group. You can see here. Fever was the most common symptom that was found in 68.9% of the HC group compared to 10.7% in the GMC group. Cough, fatigue, and dyspnea were also among the prevalent symptoms, of all of which was significantly more prevalent in the HC group. Almost 2/3 of the GMC patients remained asymptomatic, compared to 2.1% in the HC group. Laboratory data. You can see here also differences. White blood cell count, neutrophils, platelets were within the normal range, but significantly higher in the GMC group. Lymphocytes were in the lower normal range and were high in the HC group. Inflammatory markers such as CRP and LDH were also significantly higher in the HC group. The median admission in the COVID departments was 15 days, median 10 to 12 in the GMC group versus 6 days, median 3 to 6 in the HC group. Here we see the ranges of NLR and PLR. Both NLR and PLR were higher among the GMC group. You see, this is the first columns. The median NLR was 3.95 in the GMC group and 3.54 in the HC group. The median PLR was 191 in the GMC group and 175 in the HC group. Both differences were statistically significant. Discussion. This study presents the results of two very different patient groups admitted to COVID-19 departments. The first group consisted of frail, dependent, older adults with many comorbidities, admitted to COVID-19 departments in a geriatric medical center with mild or asymptomatic disease. The second group was comprised of younger, healthier patients with symptomatic disease requiring hospital admission. The results imply a strong association between NLR and PLR with age and frailty than with the severity of the COVID disease. What is known about this? NLR and PLR were previously described as easily accessible information markers that can help identify COVID severity. Both markers were found to have prognostic value in different medical conditions, such as malignancy, DVT, and more. Elevated NLR and PLR were described also to rise in frail and older patients. Their role in predicting COVID-19 severity has been described in several studies with conflicting results. Thus, Said et al. Have described elevated NLR and PLR in COVID-19 patients. The cohort they described consists of younger patients, and the severity was not assessed. Ortega-Royce et al. Conclude that NLR and PLR are predictors of a higher risk of mortality from COVID-19 in older patients. In their work, they suggest had a median age of 70, while most patients had no prior comorbidity and extremely high mortality rate was reported. Several other studies described NLR as a predictor of COVID severity and outcomes. In a meta-analysis published in April 2021, NLR was found to present significantly higher levels in advanced COVID-19 stages, showing a good ability to diagnose and predict outcomes. Most studies included in the analysis did not stratify according to age and frailty. Justin Lane et al. Described another cohort of older adults where NLR was independently associated with the progression to critical illness. It is unclear whether these patients were frail, as most did not suffer from significant comorbidities. Age and comorbidities also significantly affected outcomes in the study. Another study of older, frailer patients by Olivieri et al. Found NLR and PLR to be predictors of an hospital mortality, independent of age, gender, and other potential confounders. Most COVID-19 patients who are at high risk for developing severe illness are older patients with comorbidities. And what we found? The outcomes described are in contradiction with the results presented here that show higher NLR in the less severe COVID-19 patients. Our study is unique due to the two pools presented by the different cohorts. The results imply a stronger association of NLR and PLR to older age, frailty, and comorbidities rather than to COVID severity. We have some limitations in our study. We did not collect information on the outcomes, so we cannot discuss mortality. The length of stay was longer in the GMC cohort, and we need to investigate this. And can be result of regulatory rules for obligatory isolation at the time of the study. Maybe some patients in the HC group were presumably discharged to complete isolation at home, while the GMC patients were unable to do so. But everything begins from something. It is possible that NLR and PLR play a prognostic role after stratification according to age and frailty. Many stratification in older adults requires further large-scale studies. It is important to know that meanwhile using NLR and PLR as simple prognostic markers in older adults with COVID-19 should be done cautiously. Finally, the large differences in NLR and PLR may be driven partially by the differences in comorbidities between the groups. Most prior studies describe NLR and PLR at acute rather than chronic medical conditions. Furthermore, most COVID-19 patients who are at risk for developing severe illness are older patients with comorbidities. This emphasizes again the need for stratification of NLR and PLR before they can be routinely used for prognostic purposes. What we can learn? NLR and PLR seem to be affected more by age and frailty than COVID-19 severity. Their use as prognostic factor for COVID severity should be considered cautiously and should be stratified according to age, frailty, and comorbidities. Further research is needed to find whether these markers have a predictive ability in certain age groups or according to frailty status. The results of this study call for further research for you on NLR and PLR roles as markers of frailty. Thank you.
Thank you, Dr. Nadia, for your presentation. Any question to Dr. Nadia? Okay, no question. Thank you, Dr. Nadia.
Thanks for everybody and for you.
Thank you. We will move to the next speaker. We have
validation of heart score in a tertiary care hospital in Oman. As all we know, 9% of all patients visiting emergency, they are complaining about pain and specifically unspecified chest pain. And we have a study published 2018 by Sultan Qaboos University Nursing College, critical and adult health ICU section of nursing. They released a study in 2019. This study is showing that around 400 person of Omani per 100,000, they have some of or certain of acute coronary syndromes, and around 0.3% of them develop ST elevation MI. And because of this huge statistic and based on the improvement of the care in our hospital to improve our flow of the patient, we raise a question. Can we speed up or make a decision fast for such of cases? And here the question about utilizing of heart score. Can we utilize a heart score as a reliable risk stratification tools that can be utilized by emergency physician to assist the patient with the chest pain? This was a phase 1 of our study, and then we want to this score to be utilized by the nursing to give a decision, a fast decision in triage for the patient who is a high risk or low risk. So we carry this research question, and just before we go deep in the research, we get a brief idea about heart score. Heart score, this score was initiated and first time used in Netherlands and validated in Netherlands. It consists of 5 elements: history, ECG, age, risk factor, and the troponin. And in every element, there is a score. So the maximum score is 10 of the whole ECG for the whole heart score, while the minimum is 0. And there is subgrouping of the heart score. So there is low risk score 0.3, moderate risk score 4 to 6, and high risk score is from 7 to 10. And based on the study, person who is having a low heart score, risk score less than 3, their chance to develop MI or ST elevation MI within 6 weeks is only 1.7%. So they can be discharged faster from emergency. So we decide to carry our research and question and to improve our flow and our statistic in emergency department. So we decide to do a study of a prospective cross-sectional study. And the site is a tertiary hospital, a royal hospital, which contain a heart center, National Heart Center. This is the biggest heart center in Oman, contain of supra or subspecialty of the cardiac, and it's contained of 5 cath lab. And the duration of the research is from May to November of 2018. And the data was collected through the Shifa system. This is a Ministry of Health system to collect data of the patient. And the follow-up either by Shifa system or by a phone call. The including criteria, all patients or adults who came to emergency department complaining about chest pain. And we exclude all unclear chest pain, so we excluding them from the study. There was one small challenge is determine the sample size. So based on the previous studies and with the setting of the statistician, we decide that of assumption of an alpha 0.05, we decide we need 200 patients as prospective study. And for the safety and to increase the strength of our study, we decide to take 300. What we are going to measure? We are going to measure a major adverse cardiac event, which including mortality within 6 weeks, MI within 6 weeks, patient go for CAG within 6 weeks, or CABG or stenting, any invasive intervention within 6 weeks. So we consider it as a major adverse cardiac events. So during those duration, we include the 300 patients. We enroll 300 patients. And unfortunately, we miss 50 patients due to missing data, not completing the scoring or the data. And also, they are not answering the phone calls. So in total, in our study is 250, which consider more than sample size which is supposed to be, which is a good sample size. The results, we have results of the result. The mean age of our patient are 52. The male sex is the dominant. They are 56%, while the female is 44%. Diabetic from the population of the study is 34. Smoker 12. Hypercholesteremia 35, hypertensive is 42, and the previous ischemic heart disease 28, and major cardiac event we have among those 250, 65%, which represent 22%, they develop major cardiac event within 6 weeks. We categorize the patient in 3 groups. We categorize them in higher group. So we have a total of 36 patients in high group. 18 of them develop major cardiac events. While in moderate, we have 91 patients. 29 of them, they develop major cardiac events. In mild group or low risk group, which their score is less than 3, and this is our interest group, we have 122 patients, and among 122 patients, 9 of our patients, they developed major cardiac events. So those 9 patients, they admitted in the heart center, and during the heart center, all of them went for CAG. And when we go deep in our study, we saw the report of the CAG. 4 of our patients, they have normal CAG and discharge in the same days. And 5 patients, they have lesion in coronary and they went to be balloon or stenting done for them. So now we have 2 different results. If we assume 9 of our patients based on the study and based on our major calculation or primary outcome, 9 of our patients, they develop major cardiac event. So the sensitivity of the heart score is 83.9, specificity is 62, positive predicted value 36, and negative predictive value is 93. But if we consider only 5 patients, they have major cardiac event, and we assume that the 4 patients who have normal CAG are normal. So sensitivity of the heart score improved to 88. Specificity is improved to go down to 58, while the predictive value is 36 and negative predictive value is 95%. So now we have two groups. So to determine the strength and the accuracy of the heart score, we go for another statistic, another measurement, which is called area under the curve. So in assuming we have 9 patients who is having major cardiac events, so we have the area under curve is 0.74. While if we assume we have 5 patients only that develop a major cardiac event, we'll have 0.77, which is improving the area under curve. And the area under curve, it is used to find the accuracy of the accuracy and the reliability of the test. So now we have 2 different results. But what is the interpretation of the area under curve? The area under curve, if we assume 5 or 9, all of them, they fall on 0.7 to 0.8, which is considered acceptable discrimination. But are we going to have a test with acceptable, which is even not a good result? So this is the question that we raised in discussion. So in discussion, we have 4.2 of our patients, they are considered low risk, and which is more than the original study, which is supposed to have 1.7 patients develop major cardiac events. And the area under curve, it is, if we consider it only 5 patients will have 7.7, which is represent unreliability of heart score. So we found that the heart score is not applicable or not reliable to be used in our setting. And the reason of why not to be used in our setting, there are actually 3 main reasons. The first reason is different experience level, and experience and suspicious of MI among our physician, it is different because we have an intern, we have attached student, we have resident from different specialty, from surgery, from OB/GYN, from family medicine, from emergency, from internal medicine. They are trained in the tertiary hospital. And the second reason is familiarity, and the heart score was not familiar to be used in our emergency department. And one of the reason, it is high standard of care in the heart center. So as they take the patient who is having low threshold or low suspicious of MI, they take him for CAG, for diagnostic and therapeutic. The limitation in our study is sample size. We're supposed to have 200, but we got 300. But among those 300, only we got 122 in low risk group. So we suppose if we increase the sample size in low group, the result will be different. And also it is one site only study. So this is the limitation in our research. The conclusion, we conclude that the external validation of heart score show poor prognostic accuracy. So further study and increasing the size of sample size, it is suggested for the next study for validation. Thank you. Any question?
Thank you, Dr. Muhammad, for your presentation. Any question?
moment. So, as our lead said, the title of my presentation is Cost of Clinical Trials for Perspective of Patient Recruitment, Patients Recruitment Crisis. Short overview. I can say that so I'm as a professional in this area. So I just would like to make some global overview of the cost for the clinical trials and from the recruitment perspective. And what I have got. So clinical trial as of today, the way to provide the society with effective and safe approaches applied to the patients. It does not matter what will be diagnostic, treatment, anything which could be applied to the patient is passing through the clinical trials or must be passed through the clinical trials. And start of clinical trials as it itself appeared on the beginning of the 20th year. And now over 37,000 clinical trials is conducted annually in the whole of the world as of last year, according to the clinical trial score. And the number of patients participating in clinical trials annually is dozens of millions, and even such figure does not go in with all of the patients in the world, because some authors is indicating that only 2% of the oncological patients is participating in the studies. Cost to reach the approval is so high that it could seem that the more cost done, the more success is expected, but not in clinical trials, as it equal to the bank credit when to cut the time that to reach a success, you just take the money. So, out of effort is heading that only 1% brings the approaches to the patients or reach the market, or by other words, having overcome all approvals and studies to be safe and effective in order to give favor to the patients. And the reasons of this results is different, and one of them is recruitment of the patients to the study. So what is the absolute figures as of now? So I just took the 100 patients which could be, for example, involved in one study, and just multiply this one on the study publicly reflected in the clinical trials growth. And so we have 3,700,000 patients per year. It's very, very roughly. And the cost of clinical trials is listed below. So without cost of preclinical, for phase 1 is around 4 million, for phase 2 is around $13 million, phase 3, $10 million, then submission to for the approval around 2 million, and phase 4, so 20 million US dollars. And in total, there is $59 million. It takes only one clinical trials just to imagine the figure which could we have if we will multiply this figure and other in the term clinical research was coined in 1931, and some authors cite the results because the sponsoring company $37,000, and at the same time the losers from the unsold product were 2 to 3 orders to magnitude higher, from 0.6 to 8.0 million dollars to $23 million, and the total duration of the study is constantly increasing, in particular due to the complexity of the protocol, and as a result, the amount of information required from the site. So, for example, this one example is about the ECRF, which since 2000 until 2011 increased very dramatically. The recruitment of patients occurs at the very beginning of the study, at any phase during the recruiting period. The activity of research sites during this period affects the duration of this period, and ultimately the cost of the study and the duration of the entire study. And so you see here some other figures reflecting the cost depending on the methodology where the trials is conducting. This is also publicly observed information. So as a rule in oncology, most cost taken the study. And here is the breakdown on the years since 1393 until 2012. And this is exactly which I very love this picture, which are reflecting the cost exactly heading to the recruitment. And you see that for the phase one, it is about 15,700 US dollars. For phase two, 19. So the tendency is increasing from the phase one until phase four. And in total, also there is a so it is about 47,000 US dollars. And so you can see that only for the recruitment each year, so the sponsors, everybody, all of the stakeholders who is involved in the clinical research, clinical trials industry is spending only for the recruitment. I'm emphasizing that more than $173 billion. So, and given this figure only, and the figures which I said above before this slide, so when only 1% of the studies reach the market, it means that mostly of that figure is going to the trash. And so even with such high budget, the percentage of the budget to recruitment is again up to only 3%. So cost budget is annually in that industry. And if everything in clinical trials doing not according to the schedule, it costs more and more to the sponsors, to the end of the completion of stakeholders, to the patients. So I just calculated it's about 17 trillions of US dollars. And so what? And also from other point of view. So if we are all doing according to the schedule, we are in adherence. We are adhere to the protocol. Adhere to, by other words, it is quality. Quality conducting study conducted in quality. If we do not adhere to the schedule, so we already not doing trials in quality. So that's why, and one author is Moal Alsomide, who is I think one of the key opinion leaders in clinical trial industry. So just calculated the cost of the non-adherence, and so you see here that they from phase 1 to phase 4, then quality not adherence is increasing. So and you can see that for example, if trials do not adhere for 1%, it cost on the phase 4 study $6 million. And if we anyway trying to conduct on quality level, the cost is of course decreasing. So that's why if recruitment doing according to time, according to protocol, according to schedule, so we are decreasing, increasing the quality and decreasing the cost. Anyway, despite of such approaches, such smart approaches, such spent monies anyway, just in this year there was already concludes that recruitment, now there is a crisis in clinical trials recruitment, and it's negatively affecting patients. Most studies do not achieve the trial recruitment targets within the planned timeline. Missed milestones push back the time to analyze and report on the data. Delayed data reporting creates delays in getting new therapies approved. The delays also increase the cost of the clinical trials, and this results is higher drug prices. So also, moreover, the patients now, the new studies is now coming from the same population where studies already conducted, with more than 70% of clinical studies missing their recruitment milestones on average, and more than 4 times the amount of trials attempting to recruit from the same size patient pool since 2017. Something had to change. There's also one of the people who is key opinion leader is in the clinical trial industry. So there is a necessity to develop tools to overcome this crisis. One of the tools to decrease the cost for recruitment is to go to other countries. Why I emphasize on this, because as I'm involved in that CIS countries recruitment, so that's why this decreasing the cost, but how and what exactly calculation, and what is the figures to decrease. And so I just observed 4 studies, so they're listed here. All of them are solid tumors, and only one is a rare disease, idiopathic purpura. And here on this table, I just calculated the sum spent to find out the patients. So you see there is very much higher, less sum, but anyway, we should understand that these studies were successful in recruitment, and anyway, the cost to find out the patient is much higher, much higher. You see that from the cost of screening per patient ranging from the 3.3% to 16%. The highest cost per patient are in oncology protocols, but the lowest cost of screening is also there. According to, as I mentioned about Alsumida, the cost per patient of phases, patient range from $19,300 to $26,000. And duration of enrollment, even that this patient is successful, anyway, the duration is increased up to 300%. This is for exactly for rare disease. So, and so can be seen that target time to recruit patients increased up to 4 times. The countries of Russia, Ukraine, Belarus accounted for up to 57% of recruited patients. So it is one of the tools, but of course now again the situation is not stable, and so everything is changing. And so next tool, which I also would like to emphasize, is another tool is smart approach. Like previous presenter who is developing the evaluation of the preeclampsia. So I'm also developing the evaluation of the sites for the potential of recruitment. So, and you can find here that if it is interesting for you, the site which could be where you could you could predict your enrollment. And last sentence, clinical trial is cutting edge of science to bring the so needed medicines to the suffering patients over the whole the world. Cutting edge, always the challenge. Thank you.
Okay. Thank you, doctor, for your presentation. Any question?
They were going to talk about the hospital treatment of severe undernutrition in the pediatric population. So this is our objectives. We're going to talk about the definition, the epidemiology, the mechanisms leading to undernutrition, the classification, treatment, and repeating syndrome, and finally the conclusions. So if we're going to talk about the definition of pediatric malnutrition, we need to focus in undernutrition because pediatric malnutrition involves obesity, overweight, and undernutrition. So talking about undernutrition, the definition is an imbalance between nutrient requirements and intake that results in cumulative deficit of energy, protein, and macronutrients that may negatively affect growth, development, and other relevant outcomes in our pediatric population. That's why it's very important to talk about this and talk about the treatment. So if we talk about undernutrition, we have several definitions that involve this big definition. The first of all is wasting. That is the child who is very thin for his or her head or her height, is like very low weight. Stunting, that is a child that is too short for his or her age, that is very low height. Underweight, that is a child that is too thin for his age. And the micronutrient-related malnutrition. These four definitions is going to involve all undernutrition. So we're going to stop and talk about the epidemiology. As we already know, we have several definitions. So we have several epidemiology depending of the definition of that we are talking. So talking about stunting, we have 148.1 million children that are suffering of this stunting state in 2022 in children less than 5 years. Talking about wasting, we have 45 million children under 5 years in 2022 that was in a wasting state. And of this whole number of children, 1-2% are severe. The most of the children with wasting and stunting are in Africa and Asia in 22%. And even if the diagnosis is very simple, because you can see the child that is so thin or so short for his or her height, only 4% are diagnosed in these two states. In Mexico is where I live. In 2020, we have 1% of children under 5 years that have severe wasting. So we are very close to the numbers around the world. This is a chart that appears in the UNICEF WHO World Bank Group in 2023. And we can see the incidence of stunting in 2012. If we can see, we have like the USA that is very low in the number of children with stunting. And we can see Africa and Asia, we have a lot of children that are suffering from stunting. Countries that are playing are higher of the prevalence and stunting. And if we can see, this is the chart of 2022, we can see that the USA increase the children with stunting. Even is green, here is a little bit low, so that is not that good. But we can see also that in Africa, some countries become with less incidence on stunting, and also Asia. So this is a very important matter around the world. It's very different between some cultures and some countries. So we need to talk about the precisely treatment for each patient. So if we're going to talk about the mechanism leading to undernutrition, we have several of these mechanisms, but we're going to focus in 5 because of like the main ones. So the first mechanism on undernutrition is the decrease in the intake. If we have a children that doesn't eat what they need or her needs are, they're going to start like losing weight. So a chronic underfeeding is very important. This is because maybe some diseases, but maybe some economic or social matters that can provide them to get the food as they need it. Also, if we have dietary blood restriction, like some diseases like cancer, or maybe some gastrointestinal diseases that we can't eat, I don't know, everything. So this is going to lead us to undernutrition. Also, anorexia and all the psychiatric disorders that can lead us to eat less than as we need to. And also some kids with delayed oral motor skills that can eat properly because they have some issues here. So this is going to lead us to undernutrition if we don't do anything. So these kids that are undernutrition, maybe sometimes some excessive losses. If you compare a child that is with a healthy weight and healthy height versus a child with undernutrition, we have 26% incidence of vomiting and 22% of diarrhea compared with 14 and 12% in healthy children. So this is a consequence of this. Also, some of the kids with undernutrition have increase of requirement like seizures, dysautonomia, chronic heart disease, infection, and this is gonna lead us to catabolisms and some complications. Also, some kids has malabsorption. This is because the undernutrition state, and maybe this also can lead us to malabsorption state and also undernutrition. We can have metabolic acidosis, fat and carbohydrate malabsorption, inflammation, and dysbiosis. And finally, we can have infection, even though it can lead us to some of the complications, like we already said about the increase of requirements, but also because if you are in a state of undernutrition, you have atrophy of the thymus, lymph nodes, and tonsils, leading to susceptibility to some infection. So this is like some complication, but also it can be developed because the undernutrition state. So if we wanna classify the undernutrition, we need to talk about this whole universe of classification. First of all, we have the anthropometrics, that is the main classification, because if you have the weight, the height, you can classify to the other classifications. So first of all, in the anthropometrics, we need to take weight, height, skin folds, mid upper arm circumference, and these all measures we wanna compare to the CITI scores reference charts. We have two reference charts in the world. We have the WHO chart that are for kids for 0 to 2 years. And we have the CDC reference chart that is from 2 to 20 years. So we take all these parameters, we compare it to these reference charts by the statistic that is the CETA score. So in this, we're gonna classify in mild, moderate, and severe undernutrition. The second of all is gonna be about the etiology and the chronicity. We have some kids that are not illness related, like behavioral, socioeconomics, or environmental that can lead us to undernutrition. And we have another group of kids that are illness related. And this illness can be acute, like infection, trauma, I don't know, like diarrhea. And maybe we have another group that is chronic, that is more than 3 months, like cystic fibrosis, cancer, chronic lung disease, congenital heart disease, that is going to be a long time of the disease, and maybe their undernutrition is going to be chronic. And this can be combined with inflammation. So the mechanisms that we already talked about of the undernutrition and several, in the non-illness related, maybe the most common is the starvation. Even in the hospital, you can lead to some kids that are for something that doesn't involve the nutrition. You can lead them to undernutrition. You have heterogeneous feeding interrupts that can lead to starvation, and finally give us an undernutrition. In the illness related, we have malabsorption, nutrient loss, hypermetabolisms, and some alternate deletion of the micronutrients and nutrients. So this is gonna lead us to a lot of nutrient requirements and less intake. And finally is malnutrition, undernutrition. So we have less intake, more requirement, and this is gonna lead us to the outcome that we already talked about. Infection, immune dysfunction, delayed wound healing, prolonged hospital stay, and a little bit more. So if we need to classify the undernutrition, we need to stop in these parameters, the anthropometrics. So talking about the anthropometrics, it's very important to stop and see this normal shape, bell-shaped curve. That is the main, the main tool that we have to measure undernutrition. So if we put, I always say my patient in the private practice, I will say, if we put all the kids all over the world in a line from with the less weight, less height, and to the highest height and highest weight, we have this curve. So in the middle, we have like the normal kid, and in the opposite side, we have the undernutrition and the obesity. So this is gonna help us to classify. So we have the weight for the height, the body mass index, late or high for the age, and the middle upper heart circumference. So if we can see, this is the best kid in the world at the middle. So if we are from less than 1 to less than 2 is mild, as we can see here. To less than 2 to less than 3 is moderate, and everything that is less than 3 to, I don't know, less than 20, less than 25 is severe in all of the parameters. So in this presentation, in this treatment, we're going to focus about these kids that are in a severe state of undernutrition. So if we want to talk about the treatment of these kids, we have this 10 steps of undernutrition that give us the WHO organization and give us a simple parameter, a simple idea how to treat this patient. We're going to focus in the first 7 because it's the one that we can do it in the hospital. We're going to divide it in stabilization, that is from the day 1 to the day 7, and the rehabilitation, that is from the 2nd week to the 6th week. And this is involve all of these 10 steps. So we're going to start with the first step, that is hypoglycemia. So talking about hypoglycemia is very important because these kids are, it's very common to find hypoglycemia, and they are in a risk of doing a hypoglycemia. The definition of hypoglycemia is less than 54 milligrams per deciliter, and we have 2 scenarios. If you have a kid with severe undernutrition and you're going to start the treatment, so you need first of all to the hypoglycemia. If this the glycemia, sorry. So if you taken and is in a range of hypoglycemia, you can do these 2 things. So if the child is conscious, is okay, is alert, you can give it 50 milligrams of glucose at 10%. Or if you are not in a hospital, maybe you are in a very small town, you can use it as sucrose chelation. So you're gonna put 1 teaspoon of sugar in a 3 tablespoons of water, and you're gonna start giving orally, or maybe if this kid it's okay, but he can pass the water because he has something about the mouth or something that is can provide him to feed. You can also put an nasogastric tube. So, and then when you already arise the glycemia, then you can start feeding as soon as possible with whatever the kid is the normal feeding. If you can see about the epidemiology, most of the kids are undernutrition in a severe state is kids under 5 years. So maybe you can start formula or breastfeeding every 2 hours for the first 24 hours, then continue to feed every 2 or 3 hours, day and night. And you have the other scenario where the kid is unconscious. So you need to treat it by the solution IV with glucose at 10%. You wanna calculate 5 milligrams per kilo, or given glucose at 10% of the sucrose solution by a nasogastric tube. If you can't have the glucose, as already said, you can use the sucrose solution of 1 teaspoon in 3 tablespoons of water and give it orally of nasogastric tube. The second step is the hyperthermia. Hyperthermia is very common in malnutrition children, and sometimes indicates hypoglycemia and sometimes infection also. So you need to, when the kids arrive, take the glycemia and the temperature. If the temperature is less than 35 centigrades in the axillary or rectal less than 35.5, you need to start to warm these kids. So the first of all is to feed, because maybe it's about the glucose, so you need to feed the children, and we already talked about. All the time you need to see if they can eat, because maybe they can have some intestinal disturbance. So please you need to give some food, arise the glucose, and then rewarm the child. So you need to make sure that the child is clothed, covered with a warm blanket, a place with a heater. Maybe it's gonna be a best option. And also it's very important to do the skin to the mother. Maybe in a kids are smaller, it's gonna be easier. So you need to put your mother to the mother skin to skin, and then a blanket. You need to take the child rectal temperature every 2 hours. And this is going to be a rise to 36.5 centigrades. And you need to take it every 30 minutes so you can be sure that he is warm. You need to change wet nappies, clothes, and bedding the child as the bed is dry. And if the child is very, very cold and you have some issues to rewarm here, you can put some, you can provide the body until he is okay. So talking about the hydration is very common in children, because we already talked about the incidence of diarrhea and vomiting. So you need to be very careful on treating this kind of patient. And also you need to look at the urine output. If it is very reduced or is out of urine, is dehydration. If the patient is in shock, that is unconscious, you need to start with the IV rehydration. So we're going to talk about the kids that are unconscious. You can have it in oral or enteral by a nasogastric tube hydration. So we have two different solutions. We have the general use, that is the oral hydration solution, and we have the Resomal. The Resomal is a hydration solution for malnutrition. This solution has lower sodium, higher potassium and glucose, and less osmolarity. You can use the Resomal, and if you don't have the Resomal, you can do it by yourself. You can have the straight, have the solution of the oral retention and put it and add some potassium and glucose. I'm gonna show you the next slide how to do it by yourself. And the treatment is 5 milligrams per kilo every 30 minutes for the first 2 hours, and then continue 5 to 10 milligrams per kilo per hour for the next 4 to 10 hours. And if the kid is in shock, you need to use the ringal lactate to 10 to 50 milligrams per kilo in an IV form. So this is another way to make the Resomal hydration is 2 liters of water, a whole oral solution, the sucrose, and the mineral solution. So this is like a Resomal by yourself. And in the fourth step, we have the electrolytes. All the kids around severe malnutrition, they have deficits in potassium, magnesium, phosphorus, and they have certain rotation. You don't need to treat the edema with antidiuretic, because it is not the cause of the edema. And also, if you see an excess of body sodium, maybe it's like a fake sodium, because maybe in the real, the sodium is very low. So you need to be very careful about treating sodium. You need to stabilize the patient and then see what is the real sodium. So if we talk about electrolytes, and the most important are potassium, magnesium, and phosphorus. So you need to take the parameters of this, and you need to replace that either was by diet or IV solutions. So of these three, the most important is the phosphorus. We're going to talk about later about the reference syndrome and how the phosphorus drops very dramatically in this kind of patient when you start feeding. So you need to have a very good level of phosphorus to start feeding. So if you have a mild deficit, a moderate, or a severe, this is the treatment. If it is severe, we need to give some IV as the phosphorus for 4 hours, and they take a control. And the maintenance is a little bit higher, but you can give it orally. Also with the magnesium and the potassium. In the 5th step, we need to talk about infection. So we have multiple infections are common, fever, but the fever, if it is absent, we already talked about the hypoglycemia and hypothermia. That is a sign of infection. So you don't have to have fever to suspect or have a suspicion of infection. You have to have also hypoglycemia or hypothermia. So if we have a very malnutrition children, we need to start with a broad spectrum antibiotics, because some of the patients come to the hospital, but because they are very in a very infection state, and you need to start these broad spectrum antibiotics, because a lot of patients doesn't come to the hospital if they are in an infection state. So you need to start it as soon as they can. So if you're gonna choose these antibiotics, if it is uncomplicated severe alcohol malnutrition, you can use amoxicillin orally. And if you have some complication like hypoglycemia, hypothermia, or the child looks like very toxic, you can use it also parental IV antibiotics. But it's very important that we talk about these kind of situations with infection diseases doctor in our hospital to treat it, because we have sometimes local resistant parameters. So we need to talk this with these kind of doctors that can give us some points to how to pick the exact antibiotics. So the 6th step is the macronutrients. Very severe macronutrient children have vitamin and minerals deficiencies. So the most common is the iron that can lead us to anemia, but we need to start the iron 2 weeks from the initiation of the treatment at 2 weeks, because iron can make infection worse. Even if the kid eats okay and you don't have, you have everything like cool tips and I don't know, parameters of infection are okay, you can start the 2nd week, but maybe you can validate if the anemia is very worse to start it at the beginning, but you need to be sure that the kid is not in an infection state. So we have also vitamin A, folic acid, zinc and copper, thiamine. Thiamine is very important because the demand of thiamine increased during the transition from starvation to feeding. So when you start giving food to these kids, you need to start thiamine and vitamin D and vitamin A. So these all steps are at the same time. If you can remember, we start talking about initial feeding in the first slide. So everything is at the same time. But talking about initial feeding, it needs to be gradual, because we can have the reference syndrome where we're going to talk about later. So you need to give frequent feedings every 2 or 3 hours. If the kid is not eating enough to get to the 80% of the calories, you need to put an astrogastric feeding, and we need to encourage the breastfeeding if the kid is in this state of the feeding. So this is because these 3 main things is to prevent the reference syndrome. So we need to prevent it, like be gradual in the breastfeeding, use the timing to before the initial feeding, and increase very slow the calories. So this is a proposal of the WHO book of the treatment of undernutrition patient that gives us this kind of guidelines, that is this amount of calories, protein, and liquids. And maybe if you have the breastfeeding, well, every 2 hours the breastfeeding. But if you have this kind of milk-based formula, this F75 is a very common formula in a very in some countries that has a lot of undernutrition patients. So it's a little bit higher in calories, this formula. But if you don't have it, you can use a regular formula or a formula that is low in lactose. You can use it also a cup and a spoon or a bowl to feed the child very, very weak, and you need to feed very gradual and very frequent. So if you can see in the chart, we have that the first 2 days we're gonna feed every 2 hours, 11 millimeters. At the end, we're gonna have 130 milliliters, and this is gonna be gradual increasing. So finally, we're gonna talk about the refeeding syndrome. The refeeding syndrome is a range of metabolic and electrolyte alteration occurring as a result of the reintroduction or increase of the calories after a period decrease of absence of calorie intake. So if you can see, we have this syndrome that is the consequence of given feeding to the child. So we have this less of potassium, magnesium, and phosphorus because we start even an oral diet, an enteral diet, a parental diet, or an intravenous. So you can have refeeding syndrome in any situation, given them formula or given total parental nutrition or enteral nutrition. So we wanna, this syndrome can start for the first 4 hours to the 72 hours after the initiation of the nutrition. So you need to start the diet, put thiamine before starting diet, and measure the electrolyte every 4 hours at the beginning, so you can see if this kid is not entered to a refeeding syndrome, because the refeeding syndrome can be fatal. Because if you have very low phosphorus, mainly, they can lead to arrhythmia and some cardiovascular shock. So it's very important to diagnose this syndrome and treat it. This is a consensus of refeeding syndrome, but it's for the ASPEN, and it gives us all the clues to diagnosis and treat this syndrome. So finally, the conclusions are that in malnutrition in undernutrition patients is an ongoing problem among chronically ill hospitalized pediatric patients. The parametrics values are used worldwide to determine the nutrition status. And if we have a kid with severe malnutrition, we have a general treatment in both the 10 steps of 2 phases, the initial stabilization and the rehabilitation. Thank you.
Thank you, Dr. Anna, for this interesting presentation. Any question? Okay, thank you again. We will move.
I've been working on for a few years now as part of my doctoral thesis, together with my professors Marco Sari and Aspasia Gula, from a research laboratory of economics management, health and social policy of University of West Attica, Greece. Before I start my presentation, I would like to thank the organizers and the scientific committee of the conference for the excellent organization and the invitation to participate in the 3rd International Nursing Conference on Women's Health in Dubai this year, and I wish become open paths for further research and applications in the field of health and nursing. The topic I will talk to you about is leadership and team dynamics in healthcare, strengthening the relationship between the leader and healthcare professionals. Let's start with the first slide. Greece is a country member of the European Union. It is known to have the basic demographic issues of an aging population, as well as a decelerating increase in population. It is a known fact that all aspects of the country's economic and social life have been altered by the economic crisis, and a plethora of financial rates and healthcare rates have been detrimentally affected. In the healthcare sector, public funding decreased nearly by half during the years of the economic crisis. According to Elstat, the Hellenic Statistical Authority, relating to healthcare funding at the national level. The decrease in funding had a grave impact on the structure and function of public healthcare, including hospital care, mostly due to a lack of staff, medicine, surgical, and consumable supplies, in general equipment and facilities. The COVID-19 pandemic has left behind and continues to do so a financial crisis, which in turn is accompanied by a major socioeconomic crisis. The country members of the European Union did make an effort to slow down the spreading of the virus, to enhance and protect the healthcare systems, to lessen the social and economic impact of the pandemic, to support the workers, businesses, and other country members, and to take measures toward the relief of the economy. In such a wide social environment, leadership comes about as a purely social phenomenon that not only belongs to the one individual named as the leader, but also to all parties acting strongly in an ongoing interactive process. In other words, leadership is taken to be an intersupplied and dynamic relationship. The concept of leadership and its relationship with administration and management in recent years has been the subject of extensive studies and research in the field of healthcare. Despite the many definitions that have been formulated, it is found that researchers approach leadership both in terms of processes and in terms of personal qualities, focusing on the influence of a working group to achieve desired goals. Research has shown that empowering healthcare workers with emotional involvement in the hospital, leaders with a systemic approach and emotional intelligence that will orchestrate the collective effort, can lead a public hospital to change the culture model and turn it from a bureaucratic model gradually into a participatory one with elements of flexibility and creativity. Goleman linked the issue of emotional intelligence to the workplace, noting that under the guidance of an emotionally intelligent leader, individuals sense a mutual level of comfort. They tend to share ideas, learn from each other, make joint decisions, and fulfill their goals. They form an emotional bond which helps them remain focused on their goal, even when in deep change or uncertainty. Most importantly, contact with others at an emotional level gives meaning to the work itself. On the other hand, if the leader does not offer harmony and organization, employees will continue to work but only at satisfactory level, not applying their very best selves. Without the proper amount of soul, a supposed leader will command but will not lead. A productive work group depends directly on its leader's ability to see that substantial communication exists among group members so that every opinion is voiced in order for team members not to feel as if they have been treated unfairly. Moreover, a leader must treat each team member equally, providing team members with opportunities to show initiative, service, and responsibility. Such an ability is considered to be fundamental since it limits differences of opinion and releases the dynamics of each member. The leader has to inspire his colleagues through the role of the member because the role of the member strengthens the role of the coordinator. The leader has to understand that what he's feeling is a part of collective job and unlock his subordinate. According to Goleman, Boyatzis, and McKee, the key is the emotional intelligence for leaders, which applies to 4 sections. Self-awareness, the understanding the leader has of his feelings, needs, and capacities, as well as his limitations and values. Self-management of his inner situation, his impulse and attitudes. Social awareness, the ability of a leader to perceive the emotions and needs of others, and management of relationships, which is described as the ability of a leader to communicate with others, form relationships, and evoke the relations he desires. The significance of empathy has always existed. Hippocrates in the 4th century used to teach that certain patients are able to recover only because they believe in their doctors. Later, in modern times, numerous major researchers attempted to interpret and define it. Theodore Lipps, Freud, and Rogers were able to define empathy as the ability to perceive and approach the inner context of others. Empathetic understanding is seeing through another person's eyes, listening with another person's ears, and feeling with another person's soul. To achieve this, the individual must relax and overcome, in a sense, limitations, that is, be able to incorporate his mental self with others. The basic mechanism of perception and understanding of others is identifying, though not in its classic sense. Identifying is not with another itself, it is identifying with what another is experiencing, identifying with his experiences. In most of the answers, the participants state that emotions play a role in the field of administration and at the same time in the work that is produced and in the personal issues that the leader experiences. Although empathy is an integral part of almost all participants, what the patient experiences is expressed by all. What the subordinate feels, however, they answer that they are not able to understand and control it as they would like when needed. When asked about how easy it is to put oneself in the place of the other, the subordinate and the sick, they answer, it's the way you should operate, otherwise everything is based only on power relations. It is also necessary to convey to your colleagues the empathy of the patient. Emotions are very important in management, but they do not determine the way of management. As it is characteristically stated, the leader must care for, take care of, and protect his position of responsibility. Awareness of emotions helps him in this direction, but it is good not to express his feelings to the staff when making decisions, while when the climate is more relaxed on a more human basis, it is only natural to express oneself on a more emotional basis. Necessity of the research. Today, the issue of leadership and team dynamics in regional health units has not been extensively researched. At the same time, the findings have shown that health workers coming from hospitals in Athens, Greece, take work team and the role of leadership seriously by emphasizing concepts such as emotional intelligence, contact, mental resilience, training, and transformation. As the internal psychological processes of individuals in positions of responsibility act as mediating mechanisms in the development of a dynamic between the leader and the members of the group, this research is based on a multidimensional approach, examining the image the leader has of himself, of the position of responsibility, and the image he or she has of others, the human resources, meaning health workers and patients. This created the need to investigate the way in which the leader, through the position of responsibility and the experience gained experientially from the exercise of leadership, sees health workers. The sample came from the source population, which essentially the study population of the study. The main criterion for selecting the sample was the prospective participants who have all those characteristics related to the research case, which provided the greatest possible information for the explanation and interpretation of the study topic. The sampling method used is a purposive sampling. The sample were men and women who work in two public hospitals of the region belonging to the fifth RAE, hold positions of responsibility leaders and positions of potential responsibility deputy coordinators, and belong to the medical, nursing, administrative and social service staff, speak the Greek language, and have at least 1 year of service in the specific health units. Combined with the choice of qualitative research as a method of approaching the research field, number of the sample rose to 24 individuals with repeated in-depth interviews. Starting with the first cycle, a collection of data was pursued from the participants and continued with information and opinions of the participants incorporated into the interviewed guide of the second cycle, so that the participants could exchange views in terms of responses given, creating a mental team of experts specialists. In the present research, the number of participants was 10. Material and method. The present study belongs to the field of research and belongs to the field of qualitative research. The qualitative method was chosen as it provides the ability to recognize the individual as man collectiveness, leader followers, the unveiling of relationships between social subjects and groups, leader health professional patient, the psychosocial elements, self-awareness, empathy, social awareness, with the views and roles of a leader. The present research comes to explore exactly that, the sources from which the leader receives such abilities and actions, mainly through the experiences acquired by holding positions of responsibility in specific healthcare institutions, and from what has been recorded to this day. The Delphi method is generally a collective mechanism involving issues lacking clarity. Principles of the method have been successfully used in various fields, as well as in the field of nursing. Researchers who have implemented the method claim that their research goal was met, though it has not been used for the same purpose and consequently has not been used in the same manner. As a result, the method has been modified from its original form, having become diverse. This is a variant of the Delphi method, where participants had to answer questions containing extracts from the answers of the first round without knowing the participant who has given the specific answer, thus creating a remote group as they never actually met each other face to face. The quality data collection tool. The in-depth interview on the topic under study is a semi-structured individual interview. The aim of this technique is for the researcher to penetrate and uncover the most basic reasons that explain the perceptions and attitudes of the participants. During phase 1 of the fieldwork and after a sufficient number of conceptual dimensions, characteristics and parameters were collected, phase 2 and the final question guide of the semi-structured interview with open-ended questions were formulated, which was retested and became the interview kit. Thematic analysis. Processing of information from the individual interviews was completed within consecutive steps, including the transcription and conversion of audio information into written form according to the rules of semiology, the conscious reading of written narrations in order to locate and collect extracts referring to issues of the present research, the coding on or interpretation of meanings and definitions stemming from a synopsis of concepts, classifications, and structures which result from processing combined with the theory connected to the subject of this research. Next, from the extras coinciding with each code, followed structures of meaning that were more abstract or general and comprised the thematic categories units. From the coding, two major dimensions are developed, individual dimensions and collective dimension. In the dimension of individual belongs the self-awareness in leadership, and in the dimension of collective belongs the healthcare professionals as subordinates and members of the working group. Four thematic axes initially developed: the inner self of the leader, the interaction of inner and outer environment, the link between leader and work group, the leader in terms of healthcare professionals and patients. Then, through thematic analysis, there were three: the leader's inner self in terms of his position of responsibility, the leader in terms of healthcare professionals, and the link between the leader and work group. Results and discussion. The way the leader approaches the team members and the subordinates is considered of the utmost importance in the way they interact, influencing attitudes and behaviors and shaping a dynamic in the team. The participants speak of the assertion that a position of responsibility gives the leader the opportunity to discover aspects of himself, regardless of his professional identity, whether he's a doctor, a nurse, or a director. In most answers, it is considered that both the position and the training, as well as the way the subordinates are approached by the leader, play a role in the interaction with the team members. The leader takes the opportunity to discover their need of creating more enduring health system with precedence in experiential learning invested in the work of the human workforce. Team dynamics entail two subdimensions, the personal and the collective. It contains two persons in which one's existence is impossible without the other simply because we cannot change ourselves without one another. In the specific healthcare institutions, participants speak of inherited teams with unchanging inherited problems and characteristics. In this way, a type of culture is described where leaders cannot intervene directly. At the same time, it is stated that individuals holding a position of responsibility can be seen to gradually strengthen via experience of their responsibility and wish to have common values, mutual responsibility, and an environment of trust which will result from empathizing with the healthcare worker. A leader's role in the present study is to participate in the team by hearing and encouraging without hesitating to express feelings, by organizing and facilitating through teamwork the work on the group, promoting experiential learning, including individual and collective experience which can reform and transfigure previous experiences in a way that a new dimension of team dynamics is formed. A position of responsibility within team dynamics is thought to be by the leader a collective work experience which seems to be leading him to a further need for deep deepening and specializing knowledge of himself, creating new experiences, and laying the base for transformation from a personal to a collective existence. In other words, from first person singular to first person plural and teamwork. What is necessary is to connect personal experiences to those of healthcare professionals in a process of strength and connectedness of the internal with the external environment.
Collaborators from the Secretary of Health of the State of Roraima and from the Federal University of Roraima, Brazil. And the other collaborators are described in the slideshow. I'm going to be the presenter of the study, and my name is Bruna Benedetti Valério. Diphtheria is an acute, contagious, potentially fatal, immunopreventable, toxo-infectious disease caused by the toxigenic bacillus Corynebacterium diphtheria. It is characterized by typical pseudomembranous plaques that are often lodged in the tonsils, pharynx, larynx, nose, other mucous membranes, and skin. You can see in the picture the diphtheric patch lodged in the tonsils of the patient. The toxin reaches distant organ and systems through the bloodstream and lymphatic system, and it reaches mainly the myocardium, central nervous systems, suprarenal, liver, and kidneys. It presents as a severe and toxemic acute condition. It is a notifiable disease in Brazil, which means that every suspected case must be notified immediately due to the potential for serious impact on public health. The objectives of the study are to analyze the epidemiological aspects of diphtheria in the state of Roraima, Amazonia, Brazil from 2006 to March 2023. Methods. The study is a descriptive and retrospective study and is placed in the state of Roraima. Roraima is a state in the extreme north of the Brazilian legal Amazon and has an estimated population for 2022 of 652,713 inhabitants, and it is the least populous state in the country, with a demographic density of 2.3 inhabitants per square kilometer. The state has 15 municipalities and an extensive area occupied by special indigenous health districts, including the Yanomami people. The state borders internationally with Guyana and Venezuela, the latter experiencing a humanitarian crisis which leads to immigration. The data collected. Epidemiological data were obtained from the Notifiable Diseases Information System, SINAM, at the State Health Surveillance General Coordination, and vaccination coverage at the National Immunization System, SI-PNI data source of the Ministry of Health of the Brazil. The variables of the study are the incident rates, which were calculated per 100,000 inhabitants, and lethality rates during the study period, the vaccination coverage of diphtheria with the pentavalent vaccine, which covers for diphtheria, tetanus, and pertussis, Haemophilus influenzae B, and hepatitis B in children under 1 year of age, the homogeneity in the period of 2012 to 2022. The vaccination coverage was stratified by municipality into very low, less than 50%, low, greater or equal to 50%, and less than 95%, adequate, greater or equal to 95% to less or equal than 100%, and high, greater than 100%, and homogeneity is a performance indicator of the National Immunization Program (PNI) and is characterized by obtaining the recommended CV, which is established goal in 70% or more of the municipalities of a federated unit. Analysis. Data were analyzed using the Excel program, and about the ethical aspects, the study was not submitted to the Research Ethics Committee because it used secondary data as defined by the resolution of the National Health Council, CNS-MS number 510 of April 7, 2016. The results of the study. 7 cases of diphtheria were reported during the study period, and 1 fatal case was confirmed in 2017 imported from Venezuela. The incidence rate was 0.19 cases per 100,000 inhabitants, and the fatality rate was 100%. The fatality was from a 10-year-old male child from a mining area in the state of Bolívar in Venezuela without proof of vaccination. The case was confirmed by means of culture with proof of toxigenicity. He received anti-diphtheria serum and antibiotics, however, he died. In the figure number 1 is presented a map with the location of the Bolívar state and Scientex municipality in Venezuela and Roraima state in Brazil. You can see the number 1 is the Bolívar state in both of the maps, and the number 2 in the bigger map is the Scientex municipality, and the number 3 is where is located the state of Roraima in Brazil. In March 2023, the Center for Strategic Information on Health Surveillance, CIEVS, in Roraima issued a risk communication warning about the capture through the international media of the occurrence of 3 cases of diphtheria in Venezuela. According to the president of the Institute of Public Health of the state of Bolívar in Venezuela, the 3 confirmed cases of diphtheria are in the municipality of Scientex, the number 2 in the map. Bolívar, bordering Roraima, is the same one where an outbreak of diphtheria began between 2016 and 2020, which spread to all states in Venezuela with more than 1,700 confirmed cases and 294 deaths, according to data from the Pan American Health Organization. The figure number 2 shows the diphtheria vaccination coverage, which covers for diphtheria, tetanus, pertussis, hemophilus, influenza B, and hepatitis B in children under 1 year of age, and homogeneity in the state of Roraima from the years of 2012 to 2022. The diphtheria vaccination coverage recommended by the Brazilian Ministry of Health, which is a number greater or equal than 95%, was achieved in Roraima only in the year of 2015 with a number of 96.71%. The lowest vaccination coverage was in the year of 2012 with a number of 28.56%. In other years, the vaccination coverage was 82.63% in 2013, 86.7% in the year of 2014, 91.68% in the year of 2016, 94.24% in the age of 2017, 83.52% in the year of 2018, 64.39% in the year of 2019, 77.23% in the year of 2020, 52.08% in the year of 2021 and 60.61% in the year of 2022. The state of Roraima did not reach adequate homogeneity, which should be greater or equal than 70% in the period of the years from 2012 to 2022, and the homogeneity range from 0% in 2012 to 66.67% in 2017. In this table, you can see the stratification of vaccination coverage among municipalities in the state of Roraima from 2012 to 2022. The legend of the table are red for very low, which is less than 50%, yellow for low, which is greater or equal than 50% and less than 95%, adequate, in green, which is greater or equal than 95% to less or equal than 100%, and high in blue, which is greater than 100%. As for the stratification of the vaccination coverage by municipalities in 2012, we had 100% of the municipalities with the vaccination coverage less than 50%, which is very low. In 2013, we had 60% of the municipalities low, 13.33% of the municipalities were adequate, and 26.67% were high. In 2014, we had 60% low and 40% high. In 2015, we had 53.33% low, 26.67% adequate, and 20% high. In 2016, 13.33% were very low, 46.67% low, 6.67% adequate, and 33.33% high. In 2017, we had 33.33% low, 26.67% adequate, and 40% high. In 2018, we had 6.67% very low, 40% low, 20% adequate, and 33.33% high. In 2019, we had 46.67% very low, 46.67% low, and 6.66% high. In 2020, we had 33.33% very low, 60% low, and 6.67% high. In 2021, we had 60% very low, 33.33% low, and 6.67% high. And in 2022, we had 33.33% very low, 46.67% low, and 20% high. So, the conclusion of this study is that the main measure of control and prevention of diphtheria is vaccination. The partial decline in immunity combined with the lack of vaccine boosters contribute to the occurrence of cases of the disease. Due to the low vaccination coverage, the disease has become an important concern in public health, especially after the intense migration from Venezuela. In addition to being adequate, vaccination coverages need to be homogeneous, as the disease is rare when homogeneous vaccination coverages are obtained in more than 80% of the population. Thank you very much for listening to the presentation.